now in 2026, but as you can remember, last year, 2025, the government of Rwanda, I'm talking about the Ministry of Health, we launched the 5 HSSP, which is Health Sector Strategic Plan, which has different pillars, around 6 pillars, and these pillars are addressing at least these following challenges. One is to make sure that we improve our infrastructure and technology. There is the digital services, and also there is a human resource development and also human resource development. There will be also addressing some key programs. So you know that in the last 30 years, the government of Rwanda has achieved a very good progress in infectious disease and maternal and child health. But currently, the trends from the National Institute of Statistics and our registry data, they are showing that non-communicable diseases are overtaking in terms of incidences, prevalence, and mortality. What we can tell now is that according to Rwanda Ministry of Health mortality data, the first is now being led by cardiovascular disease. First of all, those are NCDs, but cardiovascular disease comes the first. Second is cancer. And when you go also in the number, as I'm going to present, following my keynote speech, I'll be showing that also women cancers and prostate cancer follows. I don't want to go in details just now. And as we know, to ensure this, as now cancer is concerned, we need to make sure that we deal with developing intervention, quick interventions that deals with, first of all, prevention, to make sure that our population understand what is exactly happening. That is awareness. And the first pillar that we need to work together to make sure that we can deal with this, to teach our population, but also starting by ourselves, because most of the time, we think that issues happen because the general population doesn't know, but some of us are not aware of cancer. So we need to start by healthcare professionals. And when we are not aware of this, it leads to what we call health system delays. And we'll be hearing most of us talking about what we call navigation. And navigation is to help the healthcare professionals to deal with what we call health system delays. Also, we can't achieve this without having enough and skilled human resource. That's why the 4x4 strategy, as one of the pillars of health sector strategic plan, has come to help to improve, to quadruple the human resource in four times in 4 years. It has started by within the last 2-3 years ago. And Urology Society is joining us, especially for training different subspecialty that can support within to manage this urological disease, cancer included. So we are very grateful. I know that we can't spend more than 2 weeks without speaking with Dr. Edward, talking about this coming, urology subspecialty in cancer. But also I have different colleagues. He was talking about Nyirimodoka, talking about Theophile. All these are doing these subspecialties so that you can address these challenges that we're taking Rwandans outside, because the guidance for the high leadership of this country is to make sure that what Rwanda can go abroad search for, we can train people here and address the challenges here. That's actually the goal. Whatever we're doing, we try to make sure that as the government and our partners work hardly in terms of human resource, in terms of infrastructure, equipment, and also building conducive environment so that people can find that the best area to search for best healthcare is here, and also attract people from outside in leading to what we call, medical, to make Rwanda as a medical tourism hub. Now, we can't also treat patients without providing them with best medicine, and this has come with improving, expanding the health benefit package. As we all know, Rwandans have access to health care, universal health care, through the community-based health insurance at 95%. And we are one of the few countries in Africa, sub-Saharan Africa, that provide this healthcare access. And when we talk about healthcare access, we talk about geographical access, but also financial access. Rwanda, as a small country, we have got, distribution of different healthcare facilities around the country, from referral to health centers, and now we are reaching to health posts, but also having a very good pillar that is supporting all the programs as community health workers. But we wanted also to improve NCD's access, access to NCD's care. And access to NCD's care is to make sure that you have people who can support in cardiovascular disease, diabetic, and renal disease in terms of prevention, screening, and treatment. When we talk about treatment, we talk about addressing surgical care to make sure that you have people who are skilled in management, but also access to infrastructure and equipment, and then the medicine that people need. So as we are talking now about cancer, cancer was the cancer package, or the cancer treatment was not fully part of the cancer benefit, the benefit package that was provided by community-based health insurance. Few services were included, some surgeries, but not all, some diseases, but not all. And of course, as the president has mentioned, even now, when you look at the benefit that was approved, all has not been catered. I understand, but we need also to be at the level to appreciate, because to achieve this expansion, it has been a very struggle to deal with different issues. One is to make sure that we have enough access, enough funds, first of all. We have to make sure that what we want to cover, we can achieve it, because the human resource that we have, the infrastructure we'll be using, but also the finance. And we know that where the government gets the finance is, first of all, from the contribution of the contributors, which is small as compared to what is needed. So the promise that is there is that as the government has a very good political will to improve and to expand the benefit package in different programs, there will be a recurrent review to see, according to the standards that, depending on the states that we'll be in, we will be expanding according to the means. So currently, with the urological cancers, we have first of all catered for prostate cancer, because it is the third cancer, as I'm going to show you. In the cancer registry, prostate cancer is the third. And when we take the women cancers, I'm talking namely breast and cervical and prostate cancer, we make around 60% of our cancers. So when we are now advocating for this, we go following the prevalences, the numbers. So we thought that addressing the prostate cancer, addressing the penile cancer, we at least has contributed to urological cancers. As a clinician that I am, I receive patients with bladder cancer. And when I see any patients, it's pain to me. But when it goes to policy, we follow what you call, first of all, the burden, then the efficiency and effectiveness. That's why we have not included all urological malignancies, as also you see that all female malignancies have not been included. I'm talking, all gynecological malignancies have not been included. We have included, first of all, disease of high burden, and this will be reviewed. It is not a dogma. It will be changed as we keep moving, depending on existing resources. Thank you for understanding this. I know that is a topic of debate, especially as I am within clinicians, and I understand. But let's first of all appreciate what we have got, because it is a too much effort that the government has made to expand from what was existing to add this one. Can you imagine, for example, when we talk about urological cancers, that first of all, let's talk about prostate cancer was among the first malignancy to take too much money from the funds of the government. Let's, for example, to finish this keynote, let's give an example to prostate cancer. Prostate cancer using, for those who understand radiotherapy, and most of us, we are knowledgeable about this. When you are treating a high-risk prostate cancer with VMAT modality, without using what we call hypofractionation, you need to treat your patient with 37 fraction. We usually treat with a fraction costing around 86,000 Rwandan franc. Imagine what was the cost for a Rwandan normal citizen. It was too much. Take 86,000 times 37, and then that man needs to be treated also with ADTs, 3-month Zoladex. That was also not catered for. But this time around, since we'll be having now like hypofractionation modality, whereby the patient can receive 20 fraction, and then you give your Zoladex for 2 years maybe, try to take that money that the government will be paying, but also to deal with this issue, we tried with the tariff to decrease the cost of radiotherapy, whereby the cost has decreased from 86,000 to 80,000, so that a Rwandan will be paying 80 Rwandan franc for a session. So at least so that we can now improve this accessibility, because there is no way that government of Rwanda built like a radiotherapy banker. They buy the machine and then a Rwandan pay too much. Those are the means that we are working as, your representative to make sure that at least we can have access to these modalities. So try to understand that we are trying our best, and sometimes to achieve this, Mr. President, is not easy, because we are dealing with epidemiologists, we are dealing with economists, sometimes who are not being who don't understand what we are fighting for in our clinic, but I'm sure as the time advances, we'll keep moving, and this also will be included. Thank you. Maybe I can ask the technical team to put my presentation so that also I go through the data so that people here try to understand the burden of prostate and bladder cancer, penile cancer, and then we try to see what we can address together. Thank you so much. Thank you. Next slide. So the global burden is that cancer is becoming an issue, and 90% of death occur in low and middle income countries, and this is just for simple reason. One, this population is not mostly educated in terms of NCDs, but cancer is one of the challenging issues, because awareness is very low, but also availability of means for screening is a challenge. Let's talk, for example, for urological malignancies. Rwandans, for example, Rwandan men don't come just for simple digital rectal examination and PSA, because we are not aware of this. We are receiving old men while they start just having an ability to pass urine. They have the difficulty just, when they are having like, strictures. And by this time, when someone has developed prostate malignancy or penile cancer, they don't go out and explain, so that they can go for consultation. And then they consult us when the disease, it is at late stage 3, stage 4, while the curative management is a challenge. When it is a stage 3, for example, prostate cancer, stage 4, we are having a disease, primary lesion with the T3, T4, and then level 1, level 2 nodes. When we don't have very good skilled urology surgeon, so the surgery is a challenge. When you don't have very good modality for radiotherapy treatment, the intention is of treatment tends to be more palliative than curative. And this currently now, the best modality is actually for treating the local prostate cancer, or let me talk about prostate, are brachytherapy that we don't have now. So all those are challenges. Human resource is an issue, lower level of awareness, all those contribute to this high mortality. So in Rwanda, we have high incidence, while we wanted actually to, the goal would be to take around less than 4 over 100 cases, and the mortality is high. You can see when you take 18 as incidence and the mortality is 13.8. It is more than 70%, which is high. So for the last 10 years, you can see this, we have not presented the data for 2025, and the topic was to present as of 2025. The reason is when we go for cancer registration and navigation, it takes at least, according to GlobalCan, it takes at least 2 years for a cancer disease to have all required data to have a very good, data that you can put in the cancer registry. So we are working to make sure that at least we have the 2024 data, but we still have some work to do. Now the current data is 2023, but also, as you can see, it is giving us at least a very good hint that we can see how the incidence has been increasing in Rwanda for the last 10 years. But here we are having some point to say. In Rwanda, we are not saying that actually this is an increase to show that people are getting more disease than it was not existing. One of the reasons is that since the last 10 years, you know that we had only two urologists. I think that was Professor Hedekimana and Professor Rwamasiraba, and then Prof. and Africa. We had only three. Most of us, I'm talking as being in the team, but I'm not a neurologist. So I think those are within 10 years that we have got people like Bonane, Edouard, and others. So there was no people who were sampling. First of all, there was no enough histopathologists and radiation oncologists. So we expect this may be to change to say that you have a stable incidence more like in coming years. I can't specify when, but as the statistical modeling shows, we are receiving actually 70% of people that we should be getting. So we still have actually people who are dying in the community because they have not joined our facilities. Most are still going just for traditional healers, or they die at home. So when now our people is, informed, when people are joining our health facilities, we'll be having stable incidences. But what is being shown here is that we have a high incidence as we think. People think that we didn't not have cancer, but the problem is here. That's why even we have got this specialty here. That's why the society is here joining to make sure that we can address the challenge. As now, for the last 10 years, we were getting around 600 cases. Now it has been 10 folds. So we are getting around 6,000 every year. And the most prevalent are female malignancies. Are female malignancies. First one being breast, but breast becomes the first when you combine data for women and male, and female counts. So male counts around. It's between 2 to 3. For us, it is
missing people who had missing health insurance. Yes. So here we can see that the most frequent clinical presentation was abdominal pain, followed by hematuria, and then palpable mass. Here we can see that our cohort represents relatively symptomatic patients compared to high-income countries where incidental findings of renal tumors is mostly recorded. Here, our incidental findings of renal tumors only represent 14%. So, most patients underwent CT imaging, and MRI was used in only one case. And then we can see that malignant tumors represented 63%, while benign tumors accounted for 16%. And among malignant tumors, we can see that renal cell carcinoma was the most common, and the clear cell being the most common subtype. We can see stage data recorded that here in Rwanda we saw that stage 2 renal tumors were the most common, followed by stage 1, then stage 3, and then stage 4. We can see that 23% staging data were missing, which reflects documentation challenges, which is inherent to descriptive studies. Here we can see that radical nephrectomy was the most common procedure performed, which accounted for 95%, while partial nephrectomy accounted for less than 5%. Then we can see that the most common approach, surgical approach, was open, while laparoscopy was only accounting for 11%. And we can see that left-sided nephrectomy was the most common performed rather than the right one. Here we can see some perioperative outcomes. The blood transfusion that was required was 58%, and while ICU admission represented for 14%. And also we had an average short stay of ICU, and also average red blood cell units that was used like 3.5 units. In hospital mortality, here we recorded 7%, and this we saw that the most patients who died had perioperative complications, while those who did not have perioperative complications were able to be sent home safe. And then here we can see that almost 93% was sent home. So this is the first multi-center data on renal tumor surgery that was performed here in Rwanda. And radical nephrectomy here remains the mainstay treatment due to large tumor presentation that was seen at presentation. And then we can also see that tertiary centers recorded only low complication rates, which is a good indication that here the surgeries are well being performed. And also advanced stage tumors still predominate. This is a need for earlier diagnosis. And also this research highlights both achievements and urgent gaps, and offering a roadmap to better survival for Rwandan patients with kidney cancer. Thank you.
Thank you very much. I hope everyone who has a question would write it down, and at the end of the session, we'll have a discussion and an open discussion. I would like to welcome Dr. Damas Dukundane. He's a medical oncologist at King Faisal Hospital and the head of oncology unit. Please welcome. He's going to present on advances in management of metastatic renal cell carcinoma. The floor is yours, sir.
Good morning. Thank you for inviting me. As previous speakers has said, the mainstay of management of kidney cancers is surgery. But then I will talk about what is done after surgery and when does a medical oncologist come in and what are the criteria. So there are some of the slides that I'm going to quickly jump off because my previous speakers has talked about. So like renal cell carcinoma, majority will be clear cell carcinoma pathology. Risk factors, hypertension, obesity, low exercise, smoking. So this is probably something for the physician in the room to start thinking about these risk factors and increase the screening. If you have, you can see that in other places, incidental findings are around 50%. In our data, I think I saw that it's around 14%. So we are missing something here. And all those patients and the NCDs we are having, they are there. Smoking, asbestos, these are exposures that we have. So these are most data from international, where we see that metastatic symptoms happens in other population between 25 to 30%. But in our setting, I think when you get to hematuria, that means in the previous presentation, it's around 48%. So you understand, and maybe there are some obviously patients in the community who are not being screened for that. So we need to do a better job. Diagnosis, I think we can skip this one. It's in our community, if we do ultrasound and we have suspicious mass, we can go to advanced imaging. Localized disease, this one I will probably go here. So after resection, if you have, this is NCCN 2026 that recommends that if you have after stage 2 or stage 3 surgical management, you can either do pembrolizumab if you have high grade or sarcomatoid features, or you can opt for surveillance. There are some studies that compared pembrolizumab and the standard, the sunitinib. I will show some slide later. These are the high risk features we are looking for after radical nephrectomy, so we can propose adjuvant pembrolizumab. This is based on Keynote 564 trial, where the trial demonstrated that 34% reduction in hazard for death with 1 year of adjuvant pembrolizumab compared to surveillance, and this prompted an NCCN guideline to recommend its use in stage 2 and stage 3 with high risk features. So this is the summary of the trial, and Keynote 564 being positive and leading to the approval of pembrolizumab. So this is how it was designed. Of course, PDL testing should be there, so that should be in the package of our SBA, our insurance. These are the high risk, and we can see how it differentiates when you use pembrolizumab in this setting. So intermediate high risk, and it has shown that this is overall survival when you use pembrolizumab versus placebo, and disease-free survival. And we can see that it's more beneficial actually when you have advanced, more from intermediate high risk to high risk to metastasis, you have an increasing benefit. And this is, for example, when you have sarcomatoid status versus not. So you can see that there is clear benefits. The tracing opens. So sarcoidoid features, when it's present, it is indicated for pembrolizumab. So this is a summary who should get adjuvant treatment. Clear cell pathology, PT3 or higher grade, M1, and then we should be having a multidisciplinary team to determine who gets this and where it will be more beneficial. So this is now when up front you have stage 4, what should be done? If it is resectable, it is and if it is unresectable, then you do tissue sampling, so we can see that comprehensive management of metastatic renal cell carcinoma is centered on systemic therapy, and the evidence suggests to use immune checkpoint inhibitors and VEGF target therapy as first-line options, and it should be individualized. We use I will come back to this slide. We use this IMDC criteria for metastatic renal cell carcinoma to classify in favorable, intermediate, and poor risk factors. We can see the prognosis in pre-targeted therapy and pre-immunotherapy era. You could see that favorable risk, the survival, the overall survival is around 20 to 30 months. Intermediate risk, just above 1 year, and the poor risk, less than 6 months. These are the choices that are approved by NCCN guideline to use in stage 4 disease. And this is how you can try to, all of these are approved, but in individualizing patient care, you can use some of these differences. So if you use combination of PD1 and the CTL4, you have longer time to response, you have lower objective response rate, but you have a higher rate of durable responses and a higher possibility of remission or time off to active treatment. Of course, you have, if you have PD1 and CTL4 inhibitors, then toxicity increases. If you have TKI and nivolumab, then you have faster time to response, You have a higher objective response rate, that is complete response and partial response. You have to be aware of cardiotoxicity. Yeah, and if you can go to cabozantinib if immunotherapy it's not, they are immune ineligible. So these are like the studies that compare to the standard sunitinib, which is the one that I think most of the time we get access to, and traditionally that's what would mostly be available. But we can see that all the studies show superiority of immunotherapy and TKI. So these are the factors to consider for first-line therapy. The efficacy benefits, if you and the subgroup data analysis that shows, for example, a patient who can't maybe take immunotherapy, and if you want to achieve quicker, if you want to achieve quick shrinking of the disease, and then treatment convenience depending on many factors, including availability of this medication. So this is the classification that can be used when we are personalizing this medication in high risk, intermediate risk, and low risk, with the stage, the grading, and the performance status. So in no-clear cell renal cell carcinoma, they say the treatment is not clear, so they don't respond to immunotherapy or TKIs. It's more of chemotherapy. Thank you for your kind attention.
Thank you very much, Dr. Damas. We are going next, the next presentation about relevance and limits of lymph node dissection at the time of cystectomy. Does it matter? I am the presenter. I'm Edmond Mobiri, fresh graduate urologic oncologist, and I'm happy to share the talk. Thank you. When we talk about the relevance and the limits, we need to know some few definitions. When we say limited lymph node dissection, we mean that we are in the true pelvis and just in the obstructor fossa and excluding the deep obstructor nodes. And the standards would be from the common iliac bifurcation with ureter medially, laterally the genitofemoral nerve, and caudally the circumflex iliac vein with also the Cloquet lymph node. And when we say extended, is the same as standard, but you add cranially at the aortic bifurcation, and you add presacral and super extended, we go to the level of mesenteric artery. Does it matter? When you say does it matter, we mean why is it relevant for the patient benefits, for the survival of the patient. That's why we need to ask ourselves this question. So there has been two big randomized control studies which were done. The first one was the German layer trial, which was done between 2006 and 2011, and the big one, US-Canadian stroke trial, which was done between 2011 to 2018. So the first trial, which was the German trial, was seeing the extended versus limited lymph node dissection in bladder cancer patients. And what they defined as limited is the same as standard. And the extended was the tumors which were, extended was including extended and super extended lymph node dissections. So they included patients who had T1 grade 3 tumors, resectable, and or muscle invasive T2 to 4 to T4A with no mets. And in total, they had 401 patients with dispatching 1:1 ratio. And the aim was to show a 15% advantage in recurrence-free survival to extended lymph node dissection. As you can see, the dissected lymph nodes, number of lymph nodes were 19 in limited and 31 in extended, and the 5-year recurrence-free survival was 59 compared to 65 in extended, and cancer-specific survival was 65 to 76, and the 5-year overall survival was 50 in limited and 59 in extended lymph node dissection. And when you see the complications by Clavian-Dindo grading, for those who had grade 3 or more, it was more associated with extended lymph node dissection. When we go to the SWOG trial, which was seeing between standard and extended, they enrolled around 592 patients, which were randomized in 1:1 ratio, and 292 patients were for extended and 300 for standard referendectomy, and those patients were falling in T2 to T4A disease. And the mean follow-up was 6 years. And this was a brief descriptive stage of the patient and the pathological positive lymph nodes which were found. And in total, in standards, it was 71, and in the extended 75, which were equal to 24% to 26. And the median number of positive lymph nodes was ranging between 1 to 16, otherwise, and on extended it was between 2 and 1 and 35. And when we see, we compare the disease-free survival of the two patients, of the two cohorts, we can see that patients who were who had standard lymphadenectomy had a slightly better disease-free survival and overall survival compared to extended. Because when you see for the extended lymphadenectomy, the patients who had adverse events were 54%, and for those who had standard lymphadenectomy, it was 42%. When we compare to those patients, those who had the disease-free survival were 60% in standard and 56% in extended, and overall survival was more if standard rather than extended. And the recurrency was more with extended, and Craven-Dindo complications grade between 3 to 5 were more with extended lymph node dissection. And the death with within 19 days were more with extended lymph node dissection. So overall, as a conclusion, it has been found that extended lymph node dissection does not improve the survival, and it was associated with greater morbidity and mortality, and the number of the percentage of nodal metastasis were or the nodal metastasis in extended and standard were almost the same, and local recurrence and distant mets were low and similar in both groups. And as conclusion, extended lymphadenectomy did not provide excellent outcomes than standard lymphadenectomy. Hence, advocating to do standard lymphadenectomy to decrease morbidity and mortality to the patients. Thank you. I would like to invite the next presenter, Dr. Eric Nigena, PGY2 resident, who is going to present on outcome of radical prostatectomy at 4 main Rwandan referral hospitals. Thank you.
Thank you very much. I'm going to talk about the retrospective study which was conducted on the outcome of radical prostatectomy in 4 main Rwandan referral hospitals. Radical prostatectomy is defined as surgical removal of prostate cancer, of prostate gland and its surrounding tissues like seminal vesicles. And prostate cancer is the most common cancer in men older than 50. And in the United States, 1 out of 8 men are diagnosed with prostate cancer in their lifetime. But in Rwanda, according to the WHO 2014, reported cancer death in Rwanda was 16.3% of the total death caused by cancer. This percentage is due to prostate cancer. So, the guidelines suggest that the radical prostatectomy is performed in very experienced centers, but in developed countries, they are almost approaching robotic assisted surgeries for prostate removal. But you know, a journey of 1,000 miles begin with a single step. In Rwanda, the radical prostatectomy before 2017, it was not there. So the patients who were to undergo this surgery, they had to be referred abroad. So to mean since 2017, it is where this surgery was started to be performed in our country. This is related to the availability of urologist surgeon in our country. So since then, this surgery have been done over 9 years, but there was no baseline study which was done to evaluate the related outcomes. Therefore, the aim of this study came into action. So this is a retrospective study which aimed to determine the postoperative outcome of radical prostatectomy in 4 main referral Rwandan hospitals, starting from 2017 January up to December 2024. And the main sites of this study were King Faisal Hospital, Sehashika, Sehashibe, and Rwanda Military and Referral Hospital. This study was ethically approved by the University of Rwanda and the 4 specified referral hospitals. So the findings, as we can see, the majority of our participants were operated and followed up at King Faisal Hospital at percentage of 84%, with 7.9% being at Rwanda Military and Referral Hospital, Sehashika taking 5.3%, while Sehashibe, the patient operated and followed up there were 2.6%. So here were other graphs which are not visible. So majority of our patients, based on the BMI status, majority of them were in normal weight. The overweight were 13.2, but the few number of our participants had obese at percentage of 2%. So the comorbidities which was the most to be identified in our respondents were hypertension at 44.7, diabetes at 13.2, HIV at 5.3, whereas the other comorbidities like hepatitis were recognized in 18.4%. So in clinical stage, TNM classification, the majority of respondents in our study, they fall in intermediate risk at 51.1%. We're having T1B and between T1B and T2C. In grade group distribution on prostate biopsy, the respondents, majority of them, they also fall in intermediate risk group, grade group 2 and grade group 3. At 34.2%, they were in grade group 2, which were intermediate risk group. So we also analyzed the duration of surgery, where majority of the participants were operated within a period less than 3 hours, with only 3.5% of the population it took longer than 5 hours intraoperative. So we also analyzed the nerve sparing status during surgery, where the majority of the patients, the status was not specified, and 28.9 of the patients, they had bilateral nerve sparing. 13.2, there was no nerve sparing at all, while 5.3% they have unilateral nerve sparing. So the composition of surgical team, the majority of the patients were operated by national urology, Rwandan urologist and an expert from abroad, while the small percentage, about 16%, this is the proportion of patients operated with only Rwandan urologist. So about the outcome and complications, the proportion of patients who had a preserved erectile function postoperative were 19%, whereas 18.4, they had postoperative transfusion. 7.9%, they had catheter retention, they had to be recatheterized. 5.3%, they have vesicoelectro anastomotic leak postoperative. The surgical site infection was at a very low rate, 2.6. There was no ICU admission, and there was no post-op thrombolytic disease like DVT identified. So the surgical margin status, 84% of the respondents, they had negative surgical margin, whereas the rest of the respondents, they have positive, about 16%. The pathological grade group, majority of the respondents, they fell in the grade group 2 and grade group 3. And this was from the prostatic specimen. So the matching of grade group before and after surgery, you can see that almost a half of the population of the respondents, they had misclassification. So the grade group did not match before and after, and this is likely showing the limitation of prostate biopsy. So biochemical recurrence status, about 42% of the respondents, they had biochemical recurrence, and this is suggest it's probably due to the small small sample size. And the living status, the patient who was found to be not alive after surgery and in the follow-up course, they were 5%, and the majority of them are still doing well based on the follow-up course. So the positive lymph nodes, many of our participants, we found no lymph nodes, about 89%. Only 7.9% they had at least between 1 and 2 lymph nodes. So, in our variables, the time of continence recovery in weeks from the time of catheter removal, the mean was around 8.4 weeks. The PSA nadir at 6 weeks postoperative was in nanogram was 0.6, whereas positive lymph nodes, we found only 0.2 lymph nodes were positive. So we tried to see the association between biochemical recurrence with grading and staging. And staging in TNM, the p-value was 0.46. Grading group on biopsy, the p-value was 0.45. Pathological grade group from the prostatic specimen, the p-value was 0.42. And surgical margins, p-value was 0.5. And those were not statistically strong, probably due to the raw sample size, which might be tackled in the future. So, from the study, most of the patient developed biochemical recurrence in the first 24 months. And detection of the patient with early stage might affect the biochemical recurrence in the future. So erectile dysfunction was not well studied, as some of the patients were lost in the follow-up. But however, 19% in our study had preserved erectile function. But according to worldwide data on erectile function, it was found that between 30 and 68% of the patient, they regain erectile function after surgery. So as our conclusion, radical prostatectomy is feasible in Rwandan settings, and better outcome can be achieved in early stage if detection is done before the disease is advanced. Generating a bigger sample can give a better conclusion with advanced analysis. But also Rwanda should move to a more sustainable strategy, like training uro-oncologists, but also looking to other advanced countries who are trying to put like robotic assisted surgeries in their settings to improve the future outcome on this cancer. So thank you very much. This was my presentation.
Thank you very much. We would like to invite Dr. Africa Guido Gasana, senior consultant at Rwanda Military Hospital and president of Rwanda Medical and Dental Council.
Thank you, Dr. Edmond. Thank you for giving me this opportunity to present to you the topic on the role of multidisciplinary approach in the management of cancer. This is an experience-based narrative presentation. It's not as formal presentation with data, but I want to just to advocate for multidisciplinary approach in the management of cancer, especially urological cancers. As you know, cancer care in sub-Saharan Africa is commonly affected by late presentation. It has been highlighted by most of presenters, the previous presenters, and also fragmented service delivery. Limited speciality, as we have understood in the morning, contribute to delayed diagnosis and also incomplete staging. Cancer management is frequently managed in the discipline-specific model rather than coordinated across services. This should be the coordinated model should be the standard model for management of all cancers, not only urological cancers. I want to invite my colleagues who are on the group of Rwanda Medical Association to go through the paper that have been posted by Prof. Foster, highlighting this model of, the role of multidisciplinary approach. I was going through this study 45 minutes ago before I came to this presentation. So the multidisciplinary approach involves different specialties in order to analyze the clinical and radiological findings and pathological data as well in order to operate efficiently. And this approach is actually the recommended international oncology standard. So if we embrace into this approach, then we'll be able to make decisions, and the decisions will be based on consensus following the guidelines. Because at the end of the day, we want to, we are aiming, when we are treating this patient, we aim at patient satisfaction, but also to achieve better outcome. We cannot achieve good outcome when we remain on specific, specialty model in management of cancer. I want to share with you the experience of few disciplines that have started to run the multidisciplinary approach. The breast cancer care at Rwanda Military Hospital, we have a well-established now a clinic of breast which is functional, and this involves the surgeon, the oncologist. We have even nurses within that clinic. And at the end of the clinic, at the end of the sessions, they meet again. They share, they have opportunity to share, the experience, and also make, plan for the follow-up of their patient. The same apply for maxillofacial surgery with a similar integrated clinic model. So the patients are reviewed jointly with relevant specialties in a single clinical setting. However, with this observation, we have identified some gap, and we find that the only opportunity we have to discuss cases in a multidisciplinary approach is through the tumor board, and patients are reviewed rather than being managed in an integrated manner. And when we come to tumor board, sometimes we present 1 or 2 cases because it's a tumor board for most of the disciplines. So we don't have time to go through most of our patients. So while in the clinic, integrated clinic gives an opportunity to see more patients and then discuss deeply with those who are involved in that clinic. And this approach of disciplinary-based management of cancers limit coordinated and patient-centered care. So, as I said before, this presentation is based on my experience and observation, and the primary focus was oncological service at Rwanda Military Hospital, and I realized that we need to establish a multidisciplinary clinic, as even it is advocated for the standard care of cancers in general, worldwide, and yet we are still in the specialty-specific model. So there is need to establish that multidisciplinary clinic, as now we are getting more urologists in most of the referral hospitals. At least they can organize a specific day for, I mean, multidisciplinary approach. There are some cases that are straightforward, but there are also the other cases that need a multidisciplinary approach. And why that? For better for better and accurate diagnosis, and also proper staging of the patient, because we should treat patient based on the staging, and we have to provide an accurate diagnosis and staging in order to determine the treatment options. And then in that clinic gives opportunity to discuss treatment modalities. You find that in some countries, when the patient consults an urologist, the urologist will focus on urological aspects, surgery. He will not think about oncology. Some, especially when it is in non-governmental hospitals, some they follow their interest, but you know, when the patient consults an oncologist, he may tend to, I mean, to retain the patient in his clinic, but I don't have fact for that, and it is just an external observation of what we see, and sometimes we review patients who have been treated abroad. You find that there are some monetary incentive based on the specific specialties. So we need to, within that multidisciplinary team, people have opportunity to discuss broad and even consider other aspects. These patients may have comorbidities. So that's why we can even extend the discipline to other specialties, not only radiology, oncology, but we can also extend to physician, because they may have comorbidities. We need the nurses to, I mean, to check on the diet and see how they can assist social workers and so on. So it should be a big team, but at least we provide standard care to our patients. And that prevents also, there are issues related to the coordination of referral of this patient. When you have a patient maybe who is seen in oncology and need to be seen by urologists for maybe surgical treatment, and this patient can be reviewed within the multidisciplinary rather than transferring him into the urology and wait another appointment and delay and sometimes lost for follow-up. So with that model, you take care of the patient holistically within the same clinic. And you know, announcing to someone that has cancer is not easy. We have also to engage counselors so that you know, they help this patient to understand, and this help a lot in adherence of the treatment. So with this multidisciplinary clinic approach, if established, there is positive impact where the diagnostic confidence is improved through the shared interpretation of findings, and cancer staging became more consistent and standardized. And treatment recommendations align with the clinical guidelines, and we need to, when we are in a multidisciplinary approach, sometimes some may remind colleagues, oh, you know that there is maybe a new guidelines, so we keep updated and provide the old standard care to our patients. And for the system, it reduces the delay and also the continuity of care, because in this multidisciplinary clinic, we even maintain the data of our patients so we can follow them and provide data for research and publication that can guide the profession. And service fragmented will be minimized in this model of this model of clinic. So on the clinical part, clinicians experience, they improve their, I mean, they improve collaboration and shared accountability. Doctors, we are accountable to the people that we are serving. So with this model, we provide the best treatment, the best, approach, and the patient feel that is valuable with this model because we have time to listen to them and counsel them accordingly. And multidisciplinary engagement supported professional learning, and patients receive clear communication, and this help a lot in the compliance of the treatment, and the shared decision making is strengthened through this clinic. So multidisciplinary clinic improve coordination, quality, and patient experience, and this involve surgery, oncology, radiology, pathology, nursing, allied health professionals, and the list is not limited to, when needed, you can seek help from the physician, from cardiologist, whoever you want to engage in that clinic. We don't need to have all specialty in that clinic, but based on the finding, based on a clinical finding, then you can decide who else can join the team or refer to him with clear note and recommendation. Thank you very much.
Thank you very much. This is the end of the first session. As we are moving ahead of time, I would like to open the floor for questions, and one question for each presentation will be good because we are running late. The floor is yours, please. People in the protocol may pass around the microphone, please.
Thank you. Good morning. So allow me to start by thanking the organizers of this conference. Actually, this is the first of its kind because Rwanda Urological Association is the first surgical association to organize a standalone conference. So this is something really I would like you to clap for them. That being said, I have two questions. So one for my colleague Africa, and another one for Dr. Theonest if he's still in the room. I'm not seeing him. Or someone representing the ministry or RBC. For the question around the multidisciplinarity or interdisciplinarity approach of care, I was trying to make it a little bit, moving it to patient, probably going to how people are being trained. Because sometimes I feel that we ask people to practice what we have not taught them. So we don't learn together, and we are required to practice together. So my thinking was this. So cancer surgery is unique. It's unique in multiple facets. So it asks a physician, the practicing surgeon, to be organ specific while staying a general person, because cancer is never a local disease. It is always a systemic disease with some local manifestations. And you may even start with the prostate and you end up by having a neurosurgeon, an orthopedic surgeon, a plastic surgeon, a colorectal surgeon together in just one case. And cancer can go from prevention, diagnostic, curative, palliative, reconstructive, all that you need. So now I'm asking maybe to reflect about how we can train or build better cancer surgery capacity in countries like Rwanda. So the direct question is this one. So now I'm asking this question to you as a presenter, but also as chair of Rwanda Medical and Dental Council. What is your recommendation? Would you recommend standalone programs or standalone capacity building initiatives like oncology, neuro-oncology, whatever oncology, or an integrated approach where you can have one big surgical oncology program, maybe with the multiple tracks? And second to that, the second question would be, how do we bring other team members, because we are talking about multidisciplinarity, on board? So here I mean nurses. So we training, surgeons, but we don't train, nurses, pathologists, radiologists, all the people we will need in this multidisciplinary team. Because if you come, you are the only specialist in the room. You just speak and the others listen. So there is no exchange, there is no challenge. So how do we move together? How do we bring others on board?
Thank you for the questions. First of all, we need to realize that there is such need, but again, we have limited resources. This idea didn't come up earlier because of shortage of personnel, but now, as we are getting more urologists in referral hospital, at least they can start by dedicating, for example, a day, maybe first week, last week of the month, have a joint urology clinic with specific specialties. From there, we can improve slowly. And again, engage the leadership in this approach, because I can give you an example. We have nurses who went to India for urological training, but when they came back, instead of practicing the urology, some were appointed as coordinator, another one was given another. They have never touched, even manipulate a catheter after their training. So we need to engage the leadership on this matter and start slowly, not necessarily a regular clinic, but as we improve, we can start. But again, not all urological cancers will be dealt in that clinic. There are cancers that, there are cases that are straightforward, where most urologists can manage. So not all cancers, but in a place where they have many doctors in the field, any cancer treatment, before initiation of cancer treatment is discussed within the team. But because of the shortage, we know that urologists, they can manage specific some cancers, but when discussion needed, because we do refer also some patients in oncology, instead of referring them, we give them an appointment, a short period time of appointment, so that they can be seen at least in 1 or 2 clinics dedicated for uro-oncology. Now, the training of uro-oncology, surgical oncology, it is good to have training on uro-oncology, because the uro-oncologists go beyond the clinical, but also during the training they have acquired also this capability of conducting research in the field. We should not remain on the clinical aspect, but also they can emphasize research on uro-oncology. Although research cannot be limited in that field only, there are also other areas, other urological areas that need to be, to conduct research in those specific disease. But uro-oncology, fine. But if we have good number, then that's when we can have surgical oncologists. But we need enough time to have good number of all subspecialty. But now, as there is opportunity to, we have an alumni from Egypt who is a uro-oncologist. We have collaboration with a team from Michigan, and then that can be an opportunity to train more uro-oncologists, although they can still practice general urology. Sorry for talking too much. I think I have answered to your question.
Thank you very much. I think for the sake of time, can we have a coffee break and discuss around coffee table in groups, please? Yes. There is one question from Queen. Yes, please.
Thank you so much. Mwamikazi Christians, senior nurse from King Faisal Hospital. And I have a burning question. I will ask all the team who presented, because they keep repeating about early detection will at least save many of those people with cancer. Then when we got the journey we go, the patient journey from health center, they took at least 2 years to reach district hospital. When they reached district hospital, they took another year to reach referral hospital. Then when they reach referral hospital, there is a long list, waiting list, which can take 6 months before they saw what they want, at least to know that they have cancer. Now my question is, when is that early detection going to happen? Thank you.
We can give the microphone to the Rwanda Urological Association legal representative.
Okay, thank you so much. I'm Jean Dodier Hategekimana. I work with Cancer Disease Program at RBC. Maybe I'm not going to speak on behalf of Dr. Theonest. I'm going to talk on my behalf. So Prof. Foster talked about the workforce in surgical oncology. We know it is a problem that we have here in Rwanda. As you know, cancer needs a multidisciplinary team from the early detection or prevention, diagnostics, management or treatment, and also palliative care. From that, we need nurses from the lower level. We need pathologists in terms of diagnostics and others. In management, we need physicists or surgeons in different subspecialties, and also now as Rwanda is trying to bring nuclear medicine here in Rwanda. Also, we need others who are specialized in dosimetrics or in nuclear medicine. So all those are the workforce that is needed. So in the current National Cancer Control Plan, that is from 2025 up to 2029, we tried to gather all those information by projecting those 5 years. And we have also started to have different partnership to train in all those specialties. So uro-oncology or nurses in uro-oncology are not left behind still. Talking about the early detection programs, I can assure the nurse from FISO that we are doing our best. As you know, the national programs start by tackling to those that are most prevalent. Currently, we are having the women's cancer early detection, specifically cervical cancer and breast cancer. We are doing the early medicines so that they can be available. And in terms of accessibility, someone talked about that we are having only maybe 3 centers, but currently we are building another cancer center at Sashibe that will be catering services to those from the southern and also another part of western, where by maybe the next 2 months, Sashibe will start offering chemotherapy. So it is something that we have to be grateful. It is a journey, but we believe that in the coming years we shall achieve. Thank you.
May I ask everybody to go for a coffee break and ask our colleague if you can be in the afternoon session. We'll have a better answer. Thank you.
first presenter is going to be Dr. Ahmed El Hussein from Mansoura University in Egypt. He's a lecturer of urology in Mansoura Urology and Research Center. His area of expertise is the endourology and urolaparoscopy. He has performed more than 300 cases of holmium laser enucleation of the prostate. Dr. Ahmed, if the presentation is ready and the technical team is ready, they can pull up the presentation and the Can you hear me? Dr. Ahmed? Yes, we can hear you. Dr. Ahmed, we are ready. You can try again. Also try to share your presentation. All right, we're ready. You can go on.
I can share my screen.
Yes, please.
Still telling me the host disabled attendee screen sharing. Can you enable screen sharing?
Dr. Ahmed, can you try to share your presentation again?
Okay. Is it clear now?
Yes.
Yes. Should I start?
Yes, please.
Yeah. So, Moramutse, everybody. I hope I pronounced to be invited to your first annual symposium. Thank you, Dr. Theophil, and thank you to the all responsible guys for this, inshallah, successful meeting. I'm Ahmed Al Hussein Abul Azm. I'm a lecturer and the consultant of endourology and urolaparoscopy in Mansoura Urology and Nephrology Center. I'm presenting my lecture, which is about the feasibility of holmium laser inoculation of the prostate in low resource countries and which laser should I choose. First of all, I have nothing to disclose. Let's see what are the low resource countries. This is the UN categorization of the different countries in the world. And as you can see, both Egypt and Rwanda lie in the least developed nations. And in such low resource settings, is HOLIB a feasible approach in such countries? For any prostate surgery to be standardized, we must achieve what's called the pentafecta. The pentafecta involves the safety, the efficacy, the durability, the cost effectiveness, and accepted learning curve. Since its introduction by Peter Gilling in 1998, HOLIB has proven to be safe, effective, durable, to somehow accepted learning curve. But the most important issue in our settings is the cost effectiveness. So let's see what is the published data and literature regarding this issue. In 2009, one paper published in the Indian Journal of Urology denoting that using laser is superfluous, which means non-necessary for management of BBH in developing countries based on the high cost, the questionable long-term durability, and the steep learning curve. But can the data of 2009 be applicable in 2026? Let's see. Where does the problem come from? The economic burden comes from the finance needed for purchasing and maintaining the laser machine and its disposables, the purchasing and maintenance of the morcellator, and of course the steep learning curve. Let's see what the literature tells us. In 2023, one unique article was published evaluating the cost effectiveness of different surgical approaches for BPH. And based on this study, as you can see, they evaluated the different procedures for management of BPH for prostate less than 80. And as you can see, the cost per patient for HOLIB was much less compared to the standard bipolar TRP and also compared to the prostatic urethral lift with more or less comparable quality adjusted life years. And when we when the authors evaluated the holmium laser inoculation of the prostate compared to open simple prostatectomy for large size prostates, the HOLIB was much cost effective, especially at 5 years follow-up independent of the gland size. And we, in our tertiary care center in Mansoura, we published this article back in 2018. We evaluated the holmium laser inoculation of the prostate, and we asked ourselves one question: is it a realistic endourological alternative in low resource country? In this study, when we compared the HOLIB versus transvesical open prostatectomy, 92 patients in the HOLIB group versus 91 patients in the open group, and we applied the pentafecta. The safety and efficacy comes first. For the safety, as you can see, the rate of hemoglobin drop was statistically more significant in the open group. 1 in each 4 patients who underwent open surgery needed blood transfusion. This is economic burden on our resources compared to the HOLIB. And of course, the hospital stay and the recovery duration was statistically much less with the HOLIB compared to the open surgery. And even for the complications, for the high-grade complications based on the Clavin-Diddle classification, they were statistically comparable, but in the minor complications, the open surgery had significantly higher burden due to the anemia, the need for blood transfusion, the wound infections, and the prolonged hospital stay. And for the functional efficacy, we mentioned the safety. What about the efficacy? Both are comparable. The IPSS score, Qmax, and BSA reduction were comparable in both groups, which means HOLIP achieves the same anatomical deobstruction and symptom relief as open surgery. And as a TIE, the TIE is considered a victory for the less invasive procedure. Let's come to the most important issue, the economic barrier. Of course, there is very high economic cost for purchasing the laser and its consumable, but looking at this initial high cost is short-sighted view. When we break down such costs, you can see that the high cost of the laser equipment can the high cost of the laser equipment can be fully offset by the savings in the bed days and the blood transfusions. And for after amortization of our capital equipment, you can clearly see that the holmium laser is 30% cheaper compared to the open surgery due to the minimal reusable costs. So the holmium laser is cost effective, and pay attention that when you have the holmium laser, you can use it for different urologic procedures. It is not only for holmium laser inoculation of the prostate. You can use it for the on-block resection of bladder tumor, management of upper tract carcinoma in a precious kidney, oscillatory functioning kidney, or bilateral disease. Also, you can clearly use it for urolithiasis in mini BNL and retrograde intrarenal surgery. Also, it can be used for management of urethral strictures, recurrent uretropelvic junction obstructions, and for urethral stricture for laser visual internal ureterotomy. So, to answer our hypothetical question, is HOLIP realistic for developing countries? The answer is yes, but make sure that you have adequate flow of cases in a high volume tertiary center, because the adequate flow of cases ensures reasonable costs in a relatively short time. That's for the part one of my lecture. The second part, quickly, in order to not consume much time, which laser should I use? To summarize the lasers we are using in urology, we have the holmium laser, the thorium, the green laser, the diode, and TFL. And of course, recently, the holmium and TFL have the upper hand. Which laser should I choose for the anatomical inoculation of the prostate, the holmium lag or the TFL? Of course, there is different physical parameters of both lasers, and the TFL, the most recent TFL, has much more advantages regarding the higher pulse energy and pulse duration, the higher frequency, the smaller size of the fiber. All these parameters make it perfect for stones. It allows for better dusting and in a very short time with very high stone free rate compared to the holmium laser. But in terms of the inoculation of the prostate, it is not inferior to HOLIP. They are both comparables, as I will mention. Physically, the holmium laser creates an expanding steam bubble at the fiber tip. This allows for stone fragmentation and adenoma separation. So it is a perfect dissector. That's why it is the gold standard for inoculation of the prostate nowadays. But for the thorium laser, the constant steam bubble created at the tip of the fiber allows for smoother insertion in the soft tissue. So when you use the TFL for BPH, theoretically, it can offer a short learning curve due to its superior cutting properties, resembling a laser scalpel. But going through the literature, especially this article that compared TFL to holmium for management of the PBH in a prospective randomized non-inferiority trial, no difference in all outcomes at all. They are both comparable. So my conclusion that the TFL is better for stones. It's much better for stones, even economically. As you can see, the fiber cost is much less. the laser fiber with the teeth at the OR, the 30 minutes means you save nearly $800. This is for the stools, but for the BBH, both are comparable. So your decision, which laser should you choose, should be driven by a comprehensive assessment of the clinical needs and the total ownership cost. If your center performs high volume of complex kidney stone cases, the TFL is your better choice. It has a superior dusting effect, shorter operative time, initial investment. But if you need a versatile for like Holly, for example, that system is a robust and reliable choice, especially if the initial capital expenditure for TFL is prohibitive. I'd like to thank Dr. Theophil for his invitation, and I wish you a very successful symposium. Thank you.
Thank you so much, Dr. Ahmed.
Thank you.
Yeah, if you have a question about his presentation, you can note it down. And then at the end of this session, we shall relay all the questions to him. The next presenter is Dr. Emmanuel Muhawenimana. He's a senior consultant in urology, trained in minimally invasive surgery, and he's at the end of his fellowship in transplant surgery and a lecturer at University of Rwanda. You're most welcome.
Good morning or good afternoon. It is an honor for me to be here. As he said, I'm Emmanuel Muhawenimana. I'm a urological surgeon at CHUK, the University Teaching Hospital of Kigali, and currently training in kidney transplant. So today, I'm going to take you away from cancer a little bit and drive you through the kidney transplantation program in Rwanda. So I will talk briefly on the establishment of the program in Rwanda. So kidney transplant, all of us, we know that is the preferred treatment for end-stage renal disease. So these are a few figures from the WHO estimating the end-stage renal disease burden worldwide. But for our country, Rwanda, probably also for the sub-Saharan African countries, kidney transplantation programs are very scanty. So today, I want to take you through the establishment of this program in Rwanda, where before 2023, there was no transplantation being done in the country. So the country would, physicians, nephrologists would prepare patients, investigate them, and those who are eligible were being sent abroad, mainly in India. Probably over patients who have been sent to India, 67 Rwandan were transplanted, and you can see the tremendous cost that the country has been paying, excluding all other related expenses covered by the patients themselves and their families. So in that regards, the government, the Ministry of Health, initiated a program partnering with United States universities, mainly people from Michigan, to start a program in Rwanda to be done locally. There have been steps, initiation, and since 2023, May, the first transplantation was done in the country. So, as I was saying, the development of the program was in partnership with the University of Michigan, the Ministry of Health, Rwanda. First visit was done in August 2022 for preparation site visit to assess the preparedness. Was organized overseas, and the first one was done here locally in 2023 May, together with the team from Michigan, with a local team, including our nephrologists and also the surgeon on the ground. So since then, until today, 86 living donor kidney transplant surgeries have been done, and still going on. On the program development, the training, how it is being done, every month there has been a regular visit for 1 week. So we used to have 2 surgeons from the United States and having 2 fellows initially, Rwandan fellows who are initially were urologists. Currently now we are 4, 3 urologists and 1 general surgeon. There will be a pre-visit preparation of patients with a local team, nephrologists and surgeons, including also social workers, psychologists, national committee for transplant. Nephrologists will prepare patients, HL taping, being sent to Belgium. And we have the setup at King Faisal, 2 available operating theaters, one for the donor and another one for the recipient, and we run simultaneously. So once the donor starts, and I mean, well, a couple of minutes later, then we also start on the other side for the recipient. So at the start of the program, the surgeons from the University of Michigan would be tutoring the fellows, teaching, and about a year later now is the other side. So the fellow is the primary surgeon assisted by the people from Michigan. As I said in the previous slide, we have kidney transplant unit ICU with available needed basic imaging, like duplex ultrasound whenever needed. So it is only not surgeons who are being trained. So there's already the fellowship in kidney transplantation, but also which is being learned parallel with the nephrology fellowship. So I will only talk about the surgery. So nephrology will invite us one day. So up to right now, I'm talking to you, we have 2 fellows who are almost at the end of their training are included, and we have 2 more who joined. It is a 2-year program, and endorsed by the University of Rwanda. So endorsed by the University of Rwanda with a written curriculum, with an international rotations for high volume center for more exposure, mainly Brazil, India. Well, there are continuous assessment as any other academic fellowship, and also we have available materials online. So what have we done up to that? Initially, we would skip some month, but from 2025 we are doing monthly, and every month there is 1 week starting from Tuesday to Friday. That's 4 couples in a week. Next, please. This is the distribution per year. You can see that in 2025, last year, the number increased because that's where we did really regular surgeries without interruption. Probably the previous years with COVID coming in, we had the Marburg, we had to stop for a couple of months. But now, every month, in a week, 4 couples. The visits from the Michigan has been reduced to one every 3 months. So basically, the local team with one Ethiopian guy who is on the ground as well, we run the service. What are the outcomes so far? So I will talk about the first 64 patients that we have been following for almost 18 months. So the survival rate already at 6 months, 98%. 18 months, almost the same. The gross survival, similar percentage. We have recorded already so far 2 graft losses, one for recurrent disease, another one from artery thrombosis. For mortalities, about the 86 patients that we have done. 2 from infectious reason, pneumonia, severe pneumonia. 1 from also a thromboembolic event. And of recently, last week, 1 sudden death at home that we don't know yet what happened. Diverse complication, similar to other centers. We drug toxicity. The medical part, I'll leave it for the physician, but mainly the surgical complication that we have frequently are lymphocells, psychocyte infection. We went to OR. We went back to OR 2 times at 2 occasions. One from hematoma, both of them from hematoma formation and immediate post-op. So, what are the next steps? There is a need of continued support from our partners from the United States, mainly for the complex cases and also pediatric transplants. So far, I've done only 1 pediatric transplant, 11 years old man, who is doing well. We are also shifting from open donor nephrectomy to hand-assisted laparoscopy since the beginning of this year. Well, since December last year. We have to publish our data for the region, but also for the whole Africa. And we hope that in the near future we'll be having our HLab lab in the country, which the infrastructure is being under construction for now. And we hope that in the near future as well, we also have more transplant services like liver, heart, and everything. So thank you very much for your attention.
Thank you so much, Dr. Emmanuel. So the next presentation is going to be given by Dr. Gino Ninke Bertin, who is a urological surgeon specializing in minimally invasive surgery, laparoscopy, and robotics. And he's also a uro-oncology former assistant professor at the Catholic University of Louvain in Belgium. He's currently practicing at Clinique des Ormeaux in France. He's a co-director of urology courses at IRCAD, Rwanda. He's the CEO of the Urology Medical Surgical Center of Douala in Cameroon. He's also CEO of Nyarutarama Medical Center, Kigali, and he's a former CEO of Clinique des Ormeaux, Le Havre, in France. He's currently the president of the African Association for Laparoscopy and Robotics. Dr. Bertin, can you hear us?
Hello.
His presentation is going to be la place de la chirurgie mini-invasive au Rwanda, de la laparoscopie à la robotique.
Alors,
Docteur Bertin, vous pouvez y aller.
oui, bonjour, j'essaye péniblement de me connecter, désolé, parce que je quitte actuellement une autre réunion. Alors, je ne sais pas si vous m'entendez.
Oui, on vous attend.
Allô?
Est-ce que vous pouvez
Est-ce que
essayer
vous
de parler
m'entendez?
en anglais?
Allô?
Allô?
Hello, doctor. Hello.
Allô? Est-ce que vous avez le partage
Oui, nous avons le partage de l'écran. Vous pouvez y aller. Ouais.
Allô? Est-ce que vous m'entendez?
Oui, oui.
Allô? Allô? Je peux y aller? On m'entend?
Oui, oui, vous pouvez y aller. Mais s'il
Ah,
vous plaît,
ok.
est-ce que
Bonjour à tous.
vous pouvez parler
Désolé
en anglais?
de ne pas être présent aujourd'hui à Kigali parce que je suis à une autre réunion malheureusement de consensus sur la téléchirurgie en robotique dont je vais essayer rapidement de vous partager quelques réflexions sur la problématique de la laparoscopie en Afrique. Je m'excuse vraiment, j'étais déjà à une autre présentation que j'ai dû quitter rapidement pour venir faire celle-ci. Donc je parle en fait, je voudrais parler en tant que président de l'association de robotique africaine et de laparoscopie au nom de cette association dont vous voyez ici un certain nombre de membres, dont notre secrétaire général Emmanuel qui partage avec nous ces réunions-là. Malheureusement, nous ne sommes pas encore assez nombreux pour discuter de la problématique de la laparoscopie en Afrique. Je ne voudrais pas spécifiquement insister sur le problème spécifique du Rwanda, puisque le Rwanda, en réalité, est un modèle précis de ce qui se passe dans toute l'Afrique en ce moment. Donc, en fait, on a toujours les 3 étapes de la chirurgie moderne aujourd'hui, hein, que vous connaissez, que sont la chirurgie ouverte, qui est pratiquée par tout le monde, la laparoscopie qui se développe de plus en plus en Afrique, et puis on vient perturber tout le monde avec la problématique de la chirurgie robotique. Le principe, il est très simple, c'est qu'il faut effectivement se former lorsque nous organisons des workshops. À Douala, nous avons déjà fait 9 sessions de formation. Il faut se former en invitant les médecins dans les centres qui puissent aider les praticiens à faire de la laparoscopie. Il faut s'organiser en termes de fellowship pour aller faire son fellowship là où c'est possible. Et puis, il faut bien évidemment aller dans des centres de formation comme Théophile et Edmond ont fait récemment en Égypte. Et d'ailleurs, j'ai vu entreaperçu rapidement la présentation du collègue d'Égypte sur l'OLEP. Donc, en fait, le principe de la laparoscopie, c'est la même chose, c'est-à-dire participer effectivement à des sessions de formation dans des centres de formation comme ici à Douala et comme nous le faisons systématiquement partout, comme on l'a fait aussi, comme je le fais au Rwanda, on l'a fait en Éthiopie. Vous voyez ici les équipes qui viennent former les collègues dans le training de la formation en laparoscopie. Là, c'est le centre de formation à Addis Abeba où on a fait un certain nombre de choses en laparoscopie. Ici, c'est la formation à Kigali où vous voyez qu'on a travaillé toujours en mentorship et puis on est tout le temps ensemble dans les différents types de formations pour assurer effectivement la prise en charge des patients. Donc, le principe, je voudrais être pas très exhaustif puisque je pense qu'on n'a pas beaucoup de temps, c'est que pour les interventions en général, comme je le dis toujours, lorsqu'on fait la laparoscopie, il faut effectivement être bien équipé et que l'équipement, malheureusement, est encore un frein dans beaucoup de centres aujourd'hui en Afrique, comme on l'observe. Et donc, le fait d'avoir un équipement qui est le mieux élaboré, le bien construit, pas cher, qui permette de faire un certain nombre de chirurgies de manière efficace, d'avoir des bons instruments qui vous permettent d'aborder les pratiques de la manière la plus évidente qui soit. Le bon bistouri électrique, que ce soit en bistouri classique, que ce soit en ligashore, que ce soit en harmonique ou que ce soit en ultracision, la belle colonne de laparoscopie qui vous permette de faire une bonne chirurgie sans aucune espèce de difficulté, vous permettra effectivement d'arriver à quelque chose qui est tout à fait intéressant. Alors, quelles sont les perspectives de la chirurgie laparoscopique? En général, c'est d'avoir une possibilité d'avoir une belle vision, de pouvoir faire des bonnes sutures, de pouvoir, certes, si on n'arrive pas aujourd'hui en laparoscopie et de plus en plus en robotique, on le voit, la palpation des organes qu'on opère, d'avoir un minimum de détails ou un maximum de détails possibles anatomiques qui vous permettent de bien vérifier ce que vous faites, et puis la participation de toute l'équipe qui est autour de vous qui vous permettra effectivement d'assurer cette capacité de voir, de partager les expériences et de voir exactement comment on fait et quelles sont les difficultés qu'on peut avoir. Quelques exemples pour la laparoscopie, c'est surtout la bonne sélection des patients. Et si vous sélectionnez bien votre patient, il faut que vous soyez en mesure d'être capable de bien informer votre patient parce que, en réalité, l'information que vous allez donner au patient va prévenir les potentiels risques que vous pouvez avoir si il peut arriver qu'il y ait des complications. La bonne information au préalable du patient va permettre d'éviter les petits problèmes. Il ne faut pas, bien évidemment, obliger un patient à faire la laparoscopie, d'autant plus que vous ne faites que ce que vous faites le mieux. Ceux qui font bien une technique en chirurgie conventionnelle vont le faire en chirurgie conventionnelle. Ceux qui font le mieux en technique laparoscopique le feront. Et ceux qui feront demain la robotique vont le faire en chirurgie robotique. Vous connaissez bien évidemment les avantages de la chirurgie laparoscopique. Ça nécessite donc progressivement d'avoir une certaine expertise, d'avoir une certaine learning curve, avec le risque, bien évidemment, que aujourd'hui, quel est le cut-off qu'on se fixe, quel est le seuil qu'on se fixe par rapport au nombre d'interventions. Ce n'est pas comme en chirurgie conventionnelle où on voit un cas, on peut éventuellement faire un cas et on peut enseigner un cas. En laparoscopie, le nombre d'interventions qui vous permettent d'arriver à un seuil de sécurité maximum, c'est minimum 50 malades. Donc vous voyez que pour arriver à un seuil de chirurgie assez élevé, il faudra vraiment beaucoup travailler, il faudra s'investir, il faudra aller se former, il faudra faire venir des mentors, il faudra développer le proctoring. Et ça, c'est d'autant plus important que, effectivement, si vous n'arrivez pas à combiner tous ces avantages-là, vous aurez des difficultés. Aujourd'hui, on parle de la robotique. La robotique, je voudrais quand même insister là-dessus parce qu'en fait, nous sommes à une convention là aujourd'hui à Bruxelles sur la téléchirurgie en robotique. Et qu'est-ce que je constate? C'est que la plupart des personnes qui sont là sont des personnes qui viennent des horizons, qui sont des horizons très très lointains et qui développent déjà tous la chirurgie robotique, alors que beaucoup de centres, encore aujourd'hui en Afrique, et Dieu seul sait que j'ai sillonné l'Afrique de long en large pour comprendre que le problème se pose, sont déjà en train de parler de la chirurgie robotique. La chirurgie robotique, c'est comme la chirurgie laparoscopique qui permet d'avoir un certain nombre de résultats lorsqu'on est formé. Le principe, il est toujours le même, c'est que vous opérez un patient avec une technique que vous maîtrisez le mieux, et c'est grâce à cela que vous allez arriver à avoir de bons résultats. Un pays comme le Rwanda aujourd'hui, où on a parlé de formation, hein, on parle effectivement de la possibilité pour les praticiens de faire un certain nombre de choses. La question de savoir si demain, la laparoscopie, alors que beaucoup de personnes n'ont pas, comment dire, encore franchi le seuil de la chirurgie ouverte, est-ce qu'il est indécent aujourd'hui de parler aux gens de la chirurgie robotique ou même encore de la chirurgie laparoscopique, alors qu'on sait qu'il y a encore des centres ou des pays dans lesquels il y a les blocs opératoires et il n'y a même pas encore de colonne d'endoscopie. Mais on sait très bien que ces étapes-là vont arriver. La problématique aujourd'hui de la laparoscopie et bien évidemment de la robotique, c'est le confort du chirurgien et le confort de la chirurgie, de la capacité de dissection anatomique que vous allez avoir, qui va vous permettre d'amener et d'arriver à un certain nombre de principes. Si vous comparez aujourd'hui la chirurgie robotique et la chirurgie célioscopique, vous remarquez qu'il y a un problème d'ergonomie, un problème de confort pour les chirurgiens, mais pas seulement. C'est que vous pouvez effectivement évoluer vers un certain nombre de mouvements que le robot vous permet, avec une magnification de l'image. Vous avez une vision en 3D, une magnification des images en 10 fois. Vous avez des mouvements qui sont intuitifs et vous avez une capacité d'ergonomie et de confort avec une possibilité pour le chirurgien de contrôler le système qui est tout à fait assez intéressante. Aujourd'hui, on parle de robotique, mais moi j'aimerais aussi, lorsqu'on parle de laparoscopie, évoquer la problématique de la chirurgie 3D qui fait partie de la célioscopie et qui vous amène bien évidemment à une visibilité comme la robotique, avec aussi des avantages importants de temps opératoire, de perte de sanguine très courte, de possibilité de recouvrement post-opératoire qui est correcte, avec une précision et une capacité pour le chirurgien d'être au repos avec une bonne ergonomie. Aujourd'hui, on recommande le système Bebron Esculap EV3.0, qui est un système qui vous permet d'avoir une bonne vision, une rapidité chirurgicale, une bonne aide à la suture, une grosse profondeur de champ, une réduction de la fatigue visuelle et une précision du geste. L'avantage de ce système bébronesculable, c'est que c'est un système à la fois 3D et 2D. C'est-à-dire que pour ceux qui vont acquérir le système 3D, ils vont pouvoir opérer toutes leurs interventions d'endoscopie en 2D, et lorsqu'ils font de la chirurgie laparoscopique, vont passer à la 3D. Et donc, je pense que ça permet facilement aux chirurgiens qui veulent effectivement améliorer leur confort chirurgical de passer de la chirurgie célioscopique classique à la chirurgie 3D qui nécessite un investissement qui est moins coûteux que la robotique. Que dire rapidement de la problématique de la chirurgie robotique? Je voudrais juste développer sur quelques diapositives la problématique qu'on va avoir, parce que je sais que beaucoup de pays aujourd'hui en Afrique subsaharienne sont alignés sur la problématique de la chirurgie robotique. Je pense que, contrairement à ce que certaines personnes peuvent penser, on y est déjà. Et on y est déjà vraiment à la seule condition qu'on puisse s'organiser véritablement pour créer un vrai écosystème qui va nous permettre de donner des qualifications à des praticiens pour améliorer le confort de leur formation et changer les paradigmes de la formation. Et pour cela, il faut un bon leadership qui va nous permettre à la fois d'organiser des équipes, à la fois de créer des centres de formation, à la fois de créer des centres de prise en charge tertiaires qui vont nous permettre d'arriver à déployer très rapidement le problème de la chirurgie robotique. Donc, on a un vrai problème de training à la faveur duquel on aura aujourd'hui les résidents qui vont rapidement s'imprégner de la chirurgie robotique. Alors, quand je dis ça, et nous on disait ça hier lors de la réunion qu'on avait ici avec tous les Africains, moi j'ai vu des Malgaches, j'ai vu des Sud-Africains, j'ai vu plein de gens qui vous disent, effectivement, on a beaucoup de mal de passer à la chirurgie laparoscopique, mais demain, nous sommes convaincus que la chirurgie robotique va nous apporter quelque chose qui va effectivement nous permettre d'évoluer de manière claire. Alors, il y a un vrai problème économique. Et le problème économique se pose en termes d'État, il se pose en termes d'organisation générale que les pays vont avoir pour le développement de ces pratiques. Moi, je me souviens, il y a 20 ans, lorsque en Europe, on était très fort en chirurgie laparoscopique et que les Américains n'étaient nulle part en chirurgie laparoscopique, tout d'un coup, Intuitive est arrivé sur le marché, ils ont proposé une machine, cette machine a permis aux Américains aujourd'hui d'être les leaders. L'Afrique, ce que nous voyons aujourd'hui, c'est ce qu'on a vu lors de la conférence de consensus de Casablanca qui a eu il y a quelques mois, c'est que l'Afrique est aujourd'hui en train de prendre le pas des États-Unis et qu'on voit des robots qui sont de plus en plus installés. Moi, je pense qu'on va faire très vite le saut de la chirurgie célioscopique et aller vraiment vers la chirurgie robotique. Et pour ça, il faut qu'on ait de la formation, il faut qu'on ait du proctoring, il faut qu'on ait du mentoring. Et le travail de l'Association africaine de la laparoscopie et d'urologie est aujourd'hui d'assurer cette formation et de permettre aux chirurgiens, aux équipes, de permettre aux hôpitaux, aux pays, de pouvoir investir de manière aisée sans qu'ils aient l'impression que ce soit un investissement à fond perdu. Et croyez-moi, on y est très proche et très vite, ceux qui vont prendre le pli de la laparoscopie vont comprendre que effectivement, pour nos pays en Afrique subsaharienne, la problématique de la téléchirurgie que nous développons aujourd'hui est très importante. Ça veut dire que vous allez avoir des robots installés à Douala, à Lagos, à Kigali, à Abidjan ou à Nairobi, et vous allez avoir des chirurgiens qui vont supporter les équipes qui sont ici ou là à opérer les patients parce que cette téléchirurgie va permettre d'apporter une bonne capacité de prise en charge des patients avec le système. Alors, que choisir? Alors, le problème se pose aujourd'hui dans les conférences de consensus. Il y a beaucoup de robots qui arrivent sur le marché. Quels sont ceux qu'il faut choisir? Moi, je vais juste vous faire, et je vais terminer là-dessus, un update de ce qui se passe aujourd'hui en Afrique, parce que j'étais chargé de poser le problème lors de la conférence de consensus. Aujourd'hui, au Maroc, vous avez presque 10 plateformes. En Algérie, vous avez la plateforme RevoEye qui va s'installer et ils sont en train de discuter pour installer le système Agibot qui va arriver en Tunisie. En Angola, vous avez déjà presque 6 plateformes. Au Nigeria, vous avez 3 plateformes avec une qui est en train d'arriver. En Égypte, on parlait d'une plateforme, je ne sais pas si elle est fonctionnelle ou pas. Au Rwanda, on parle éventuellement de 2 plateformes en 2026. Au Cameroun, il y a une plateforme qui sera installée dans les prochaines semaines. En Côte d'Ivoire, c'est la même chose. En Afrique du Sud, vous avez déjà 13 plateformes qui sont installées. Et vous voyez que dans le monde multiculturel de la chirurgie mini-invasive, on ne parle plus de la chirurgie laparoscopique, on parle de plus en plus de la chirurgie robotique. Existe sur le marché en 2025-2026 tout ce que vous voyez là comme euh, machines sur le marché, en passant par Medbot, en passant par Edge, en passant par Shirui, vous avez le système Moon, vous avez le système CMR, vous avez le système Inotori, vous avez le système indien. Et donc, nous, on pense que pour développer la chirurgie laparoscopique ou développer la chirurgie robotique qui va s'installer, croyez-moi, dès 2026 en Afrique, il faut former les gens, il faut créer des diplômes. Il y a des formations, il y a des trainings qui sont organisés. Il y a eu des trainings de laparoscopie qui ont été faits au Cameroun, au Rwanda. Il y a un DU de formation de laparoscopie auquel nous participons au Burkina Faso. Il faut des centres accrédités, ce que nous sommes en train de faire avec l'Association africaine de laparoscopie et de robotique, d'accréditer les centres. Nous sommes en train d'accréditer les centres au Maroc. Il y a des centres en Tunisie qui sont en train de se former. Il y a des centres à Douala qui vont être formés. Il y a des centres à Lagos qui sont en train d'être formés. Il faut de l'expertise, il faut du mentoring, il faut du proctoring et il faut des fellowships qui sont en train d'être organisés. Comment on les organise? Les différents niveaux, vous les connaissez. C'est le dry lab, c'est le wet lab, c'est des centres de formation comme l'IRCAD. On développe de plus en plus du e-learning avec le site de l'association africaine africasurge.com où vous allez trouver des vidéos qui sont postées par des experts africains qui vous montrent les interventions qui sont faites. Demain, on va développer l'intelligence artificielle qui va développer la machine learning, la deep learning, et puis bien sûr, on développe aussi le proctoring et le mentoring. Ne pas oublier, oui, oui, j'ai fini. Ne pas oublier, bien évidemment, la formation des paramédicaux et bien évidemment, c'est très important de faire leurs évaluations. Je vous remercie et j'en ai fini avec cette formation. Je montre juste cette dernière diapositive pour montrer comment on peut organiser une formation en 2 jours pour que les praticiens qui ont déjà une façon de faire puissent s'en sortir par rapport à la formation en laparoscopie. Bien évidemment, vous n'oubliez pas le fameux ECAD qui nous est si cher à Kigali. Merci beaucoup.
A fresh graduate from Reconstruction. He's going to tell us about the long-term survival outcomes for proper travel for kidney transplantation in Rwanda, a benchmark study.
Good morning, everybody. As you said, my name is Dr. Théophile Ndaishimie. I'm a urological surgeon at the military hospital, and I think I should have given my presentation before Dr. Emmanuel's presentation. Unfortunately, I'm more junior to him, so he passed in front. Because I'm going to bring up problems that traveling for kidney transplantation bring about, and his program came to solve that. Can you have the slides, please? Okay. He already said that kidney transplant is the preferred modality. I will not go into that again. But worldwide, the current challenge is about organ donation. More people are running away from giving their organs for whatever reasons, whether they're saving a life for somebody else. And most programs now, at least in the West, are relying on deceased donors. But in Africa, that's probably not yet a problem, because most populations and families in Africa are still willing to give organs, and we can still rely on that. And most of the programs in Africa are still relying on living donors. And an additional problem in Africa is that we have issues with the unavailability of the programs, and transplant services, which are very rare. We'll look into that. Okay, sorry. Okay, back to that. Okay. So this is a slide to try to show how even the deceased donor. Previous slide, please. Even deceased donors have dropped. There was a steady rise over time, and then from 2017, 2018, there was a sudden drop, and then during COVID time there was a significant drop, and then after that there was a trend is going back up, but it's not yet at where it was in 2018. Next. This is for living kidney donors. It also dropped significantly, but it's also going back up. Next. These are about the programs that are existing in Africa. I try to focus only in Sub-Saharan Africa. But the Rwandan program started in 2023, as Emmanuel said, so that's why all the patients that I looked at during this study were all operated before that time period, and they were traveling away in other countries to get the service. So most of these programs are very intermittent, or they have low volume, even especially in Sub-Saharan Africa. But South Africa has a very strong program, and the Maghreb countries also have good programs. But in Sub-Saharan Africa, we're still having issues of funding and volume. Next. So, as I said, in Rwanda before 2023, the patients were traveling. That dates for a long time ago. Very sure Prof. Gamasirabo is aware of that, and the other urologists that were there then. But there are a lot of problems with this practice, and that's why the government invested in bringing up a new program that can address these issues. Major issues usually are related to donor evaluation, because most of the centers that patients go to were most of the time private centers, and they would push to have they would ignore details to have that patient operated on. And usually there are issues with regulation, so which is usually going to have impact on the outcomes, because of there are no quality assurance controls that are tight as in-country programs. Infectious screenings and other modalities are also not as well as you would wish to have, so patients end up having poorer outcomes. This is a table trying to show how the patients who were transplanted within the countries compared to patients who traveled abroad. I made a reference to meta-analysis from Europe and America. It looks like at the first year it's already dropping down, so there are already significant differences, but at 3-5 years it is even worse. At 10 years the survival are very, very different. So we looked at we conducted a retrospective cohort study to try to look at the outcomes of our patients that have been traveling abroad from 2008 to 2021, and we included both the patients that were self-sponsored and the patients that were funded by the government, which is the bigger proportion. Next. And on this analysis, you can see that there was a steady dropping of the survival of these patients, both the graft and the patients themselves. Next. This is the survival probability for the patients, trying to compare with male and females. Females looked like having a better survival, which we cannot explain. Maybe they take a good care of themselves more than men, or men are taking more dangerous engagements. I can't fully explain that. That's probably beyond our study. Next. And on this one, we try to split, because most transplant programs tend to favor young patients, saying for economic reasons. But we tried to look in this study to see whether there was a difference And we found there was a slight difference, but that was not statistically different, significant. This is trying to look at the effect of having comorbidities. There was a compound risk profile here. Patients with diabetes tended to have more compromised survival or graft survival, patient survival and graft survival, but that was also not statistically significant. And the overall graft survival also dropped. It's not only the patient survival, but also overall graft survival also dropped, and we were at about 68% at the end of the follow-up, 10 years. Graft survival by sex did not differ at all, but and this one was trying to look at the patients who did the hemodialysis before getting a transplant. It didn't look like it made any significant impacts. Most of the patients who were probably due to get a transplant got it early, but we still didn't get any statistical difference, which may be also due to a smaller sample size that we had. So if we try to compare to other studies, it drops for every study that I looked at, all the meta-analysis and any literature reviews that we looked at. All the studies report there is a decline after at least the first year. There's a significant decline with time, and it goes all the way down. But you can see that the patients that traveled abroad to have a kidney transplant, we get less survival, and less the survival of the patients and less survival of the graft. Next. Okay, so we had our study. We were limited by a small sample size, and it was also a retrospective study. So we had to exclude a couple of patients because our record keeping wasn't the best, and also we didn't have access to everything, like the data that the patients had when they were in India, mainly, which was the main country of transplant. We couldn't have access to perioperative data and the scenarios like the acute rejection immediately after the transplant. Most of the patients did not have accurate information, or that was not recorded within our EMR. Bring back. Okay, I was going to talk about the advantage of in-country program, but I guess Emmanuel has already presented about that, and we are going to benchmark you based on these results. We'll see what we will achieve with your program. Thank you very much.
All right, thank you so much to all the presenters. So to the audience, if you have any question, this is your time.
It looks like there are no more questions. Maybe we proceed. Oh, you have a question? He didn't have a question. Yeah, you have a question? Yes, yes, sir.
Thank you very much for the
presentations. And thank you also the colleagues that presented from overseas, Dr. Ahmed and Dr. Njino. I'm very, very happy, you know, with the way the urological community in Rwanda was able to come together and organize our first conference, which is going to be taking place every year. And I think this is a great achievement, and I wouldn't mind really ask people to give you a round of applause. So coming to questions, because when you make presentation, there are always questions. I would like to come back to Emmanuel. Sorry, Emmanuel. You know, this is our first program. 86 transplants done locally since 2023. And also having almost 2 or 3, I don't remember, certified transplant surgeons. This is great, and congratulations. It takes really, to believe in it and continue doing. Emmanuel, you've given us statistics, but we would like to hear more. I don't know who was championing qualitative research recently. Yes, that's Faustin. Faustin is here. Tell us, how did it work? I'm sure there are some hiccups that you had. We would like to hear from that and what actually happened. You just went to theater, you started fixing everything, or you had some hiccups? Can you be free and tell us how it went on? Thank you very much.
Thank you, Prof. It's a difficult question, but I'm going to try to summarize. Maybe I have to go forward. As a new program in the country, and then in a developing country, I wouldn't say it was an easy journey. So, no, it wasn't. So as I presented, the government had to bring in partners, and the difficult step was first to put up a team, because many of us, we are surgeons. What is more important is not the surgery, but what happens around the surgery. So with our colleague nephrologist, patient selection, having all the setup, the theater, ICU, nursing team, you need a dedicated team of nurses who understands what you're doing, the physiology after transplantation. So all those small details, especially into the, let me call it workforce, the personnel, it was really very important for the program to run. So the nurses had to be trained as well. Our general nephrologist had to be more oriented into transplant nephrology. then comes the equipment. So you need to bring in more sets. You need more sutures that you are not using in conventional surgeries you are doing every day, and that is the part now of the hospital management. So really there is a part of clinicians, there's a part of the government, there's a part of the hospital management, and bringing all those together to come up now to a running program require a well-coordinated team. But there is also, besides training people, surgeons or nephrologists or nurses, there is also our patients. So Africans in general, people probably think we are very friendly. This is a living donor program. So you need someone to give someone else a kidney. Sometimes many of our patients, the donors, they are relatives, but we also have non-relatives, so unrelated people coming for donation. You understand, everyone knows what is happening in other worlds. Here we're talking about organ trafficking. So all of those things, on one side you want to save someone's life, but on the other side there might be also some trickiness. So there have been so many challenges, and the coordination with the support of every participating organ has been really of great impact to the program to be running until today. And we are really very grateful to the Minister of Health and King Faisal Hospital management for their participation and their active involvement for the clinical part to be running as it is today. Thank you. I think that's the brief story I can say.
Thank you, Dr. Emmanuel, for your insights. We are going to quickly go through a short session where we have only 4 presentations, and every presentation is just about 10 minutes. And allow me to invite Dr. Yves Bizumuremyi Mugisha Constantin, and who is going to take us through. He's a urologist and he's based at the Butare University Teaching Hospital in the south. And I'm sorry to say, but he's the only urologist who is working out of Kigali, but he's doing an amazing job. Everybody should probably clap for him. Yeah. So he's going to tell us about outcomes of surgery for anterior urethral strictures in Rwanda. He conducted a cross-sectional multi-center study. Thank you. Go ahead.
Good morning again. So we have been seeing urological cancers previously, but let's turn again through other urological management. So we are going to see the constructive part. We are going to see this study conducted to determine the area outcome of surgical management. So as we know, male anterior urethral stricture is a scarring of the subepithelial tissues of the urethral epithelium, which leads to decreased lumen of the urethra and then lead to decreased urinary flow. And so it is caused by many etiology. It may be from trauma or inflammatory diseases like STI. So stricture management is a challenging part for urological management of the disease. So it has got about 10 to 20% of stricture recurrence because it's a scar, surgical scar. So we conducted this study to see the determinant which may affect the recurrence. Next, please. So this study was a retrospective analytical study conducted in 4 main referral hospital in Rwanda having urological services. So the population was all male with urethral stricture operated between the period of study from January 2019 to up to April 2021. So we collected the data retrospectively from patient archived files and electronic medical records from different hospitals. While the prospective study was collected during consultations or the new cases and during operative time and then in the OPD follow-up. So the predictors collected was the patient's demographic features, clinical characteristic of the stricture, preoperative details, and the postoperative outcome. So the presumed predictors was age, comorbidity, etiology of the stricture, length of the stricture, location of the stricture, stricture caliber, surgical approach, either endoscopic or open, duration of the procedure, and the type of open surgery, the type of catheter used, and postoperative SSI and type of suture material used. Next. So the main outcome was stricture recurrence after 3 months postoperative, which was defined as visible urethral stricture on the CUG and image or inability to pass a standard 17 French cystoscope or catheter, urethral catheter. So the data was analyzed with SPSS version 23, and we did biovariate and multivariate analysis. So next, please. So 112 male patients were enrolled, and their data was collected. So the findings, we found that the disease, stricture disease, was of the young age. The mean age was 43-year-old, and the overall stricture recurrence was 15%, and the most stricture was located in the vulvar part of the urethra. So 17% were having recurrency. Next, please. So after bivariate analysis, we found 3 stricture length greater than 2 centimeter to be as the predictor, with a p-value of 0.015 together with a stricture caliber or which was greater than 50% of the lumen, to be another covariate with a p-value of 0.1. Next, please. So the two determinants were taken for, and also the SSI and the UTI were covariate, and the next, please. After we took the co-finder in the multivariate logistic regression analysis, where we found only structure length of greater than 2 centimeter to be the significant risk of structure recurrence with a p-value, a significant p-value. So as conclusion, we found that the structure disease is a disease of young adults, and the structure length greater than 2 centimeter was associated with high recurrence rate. So, and we needed more extended study to identify other hidden determinants. So, thank you very much. That was our findings.
Thank you very much, Dr. Eve, for keeping the time, especially, and giving good insights into your study. We go for the next presentation. If they allow me, I'll be the next. Yeah. Okay, so we're going to, we have a question that was raised by the study that we conducted looking at the pelvic fracture urethral injuries in Rwanda, where we found that infection was a factor for recurrence. We don't hear, as a urologist, we don't hear much about this as a factor. So we wanted to look at why this question, can we look at the research, and should we actually modify our antibiotics prophylaxis? Because we are currently using mainly guidelines from Europe and America, and we don't have our local guidelines, which guidelines we use and are extrapolated from not our studies and not our patients and not our settings. So PFUI repairs, unfortunately, are not very common in the surgery itself is not common because most sub-Saharan Africans don't have the proficiency to do these procedures. But the cases are there, and they are more severe than what you see in the Western world. So, however, we have the similar recurrency rate, which is about globally 19%. But then this is a compilation of RUA and middle-income countries plus the high-income countries. But most of these studies that are reported in the low and middle-income countries are usually from big centers. You find studies from Egypt, you find studies from India, from the Kulkarni Center, which is a very well-known center for reconstructive urology, but they still classify India as LMIC, so you take these studies and they'll be into this. We have the infection in the PFUI. They are reported up from 2 to 25% of pelvic fractures repairs. And usually when you have a trauma, the gold standard is putting a suprapubic tube and wait and do a urethroplasty from 2 to 3 months usually, but the guidelines usually talk about 3 months. And we hypothesize that inflammation that results from the infection is going to cause fibrosis around the anastomosis, and then you get a structure recurrence. So we conducted a multi-center study at the 4 hospitals, and we include 47 patients. Patients that were included were operated before 2022 were included retrospectively, and those that were operated after 2022 22 were included prospectively, but this cohort is about 67% of the patients. So we had the median time for surgery was about 1.4, but the median was the interquartile ranges were very, very high. We had one patient who had surgery. I always joke with Prof about that patient who had surgery after 20 years of carrying a suprapubic tube. That was very strange. So infectious complications, we had about 14.8%. And these are usually UTIs, and then surgical site infection was about 4.2%. And all the complications were mild, and the mean catheter duration was about 32.5 days, which was close to an acceptable range. So the outcomes that were a surprise to us was that having a symptomatic urinary tract infection was the strongest predictor of recurrency in these patients. Most of other studies talk about this. They say that infection or surgical site infection is likely to cause inflammation in the anastomotic site and then cause a fibrosis, but no one has put it separately and say UTI separately, does it cause something? I was trying to look up if there's any meta-analysis yet. I didn't find a study yet, but I found a recent study that was published in July 2025 that talks about infectious complications in the perineum, including surgical site, hematoma, UTIs, contributing, increasing the likelihood of having a recurrency. So, next. So these were not associated with recurrency, but we found that preoperative urine culture, which, if it was positive, also led to postoperative urinary tract infection, which we hypothesize maybe was due to poor adherence of the patient to the medication. Other places, like in high-income countries or in Egypt, where I was, they usually, if you have a stricture patient that you want to do a erythroplasty, they usually change a catheter probably 2 weeks before that, and then they make sure that a urine culture is done before you can go to theater. So we don't necessarily do that practice here. We keep changing the catheters monthly until we do surgery, but we probably should go to this practice now. And the defect length and then all of this list of others did not make any difference. So the AUA and EAU guidelines, they all say move away from antibiotics. They don't do anything. Keeping the patients for antibiotics for longer doesn't make a difference. But we probably should look into our own patients' population and maybe generate a hypothesis that we need to investigate further and see whether we have to probably put patients to antibiotics a little bit longer, probably. There's one study that was published also in 2022 that says giving one shot of antibiotics at the time of catheter removal also reduces the occurrence of UTI and recurrency. We should probably try to do that practice too in our routine practice. And unfortunately, all these recommendations are extrapolated from high-income countries' data. We should probably be doing more research in our settings and based from our own data. So the reality from the high-income countries is a little bit different from ours because we have our own challenges of patients getting prolonged catheterization, patient having limited access to catheter. I've seen patients coming from very far away, traveling for 3 hours to come only to change a suprapubic tube in Kigali, while that can be changed close to their home. So it's still a problem that we probably need to fix and or maybe try to educate better our general practitioners and other people that are doing the job in primary care. So should we implement a different strategy? I don't know. I cannot base on this single study to say that we have to do this, but we probably need to set in a prospective study to try to look at this and then probably edit our protocol and guidelines accordingly. Next, please. So some evidences suggest that there might be a link between the infection and recurrency, but there are not strong data that is available. So we probably need to look into that, maybe conduct better prospective studies to decide on this. Next. That I have already answered. We need to look at our IPC practices in our hospitals and theaters, but also educating our patients and also trying to detect as early as we can. And if we have a patient that we suspect that they have probably an infection or a urine leakage in the after repair, probably doing the AUA and EAU guidelines now do not recommend routine VCUG before you remove a Foley catheter after urethroplasty, but we probably should be doing that in patients that we suspect that are at risk of having a recurrency, so that will probably be addressed at separate individuals. My take-home messages will be that we have successful outcomes in LMICs. Our study found about 19% of recurrence, which is very much comparable to high-income countries settings, and postoperative UTI was a major risk factor for us. We should be looking into that, into a better and prospective study, and also look away from not looking totally away from the current high-income countries guidelines, but try to find guidelines that work for us and that work for our patients. And that, to decide that, it has to be based on our own local data. Thank you very much. Our next presenter will be, I would like to invite Clemence Mutoni. I saw her. Clemence Mutoni is a resident, a senior resident, chief resident. I'm sorry, madam. I'm very sorry. She's the chief resident of urology, and she's going to take us through her study that looked at patient-reported outcomes measures following urethroplasty in Rwanda, what we have been lacking in our routine practice. We've been doing patients and then send them for imaging or whatever, or cystoscopy, but no one has ever conducted a study before to look at the patient perspectives. And she's going to take us through her study. Thank you. Welcome.
Thank you. Good afternoon, everyone. Can I share my presentation? Okay. My study is entitled Assessment of Quality of Life and Satisfaction, Patient Satisfaction Post-Urethroplasty. I was using the urethral stricture and symptom impact measure. This is a patient-reported outcome. Worldwide, the urethral stricture disease is prevalent at approximately 300 to 100,000 in men, and urethroplasty is the treatment or is the gold standard for urethral stricture diseases. And in Rwanda, it's approximately, we do around 212 urethroplasties per year, but these are not specifically for urethral stricture. We may even do urethroplasties on patients who have congenital malformation and other causes. So the main objective of this study, there are mainly two. One was to assess patients' satisfaction or patients' patient satisfaction and quality of life after the surgery, and using this study, the USSIM, and this USSIM is validated in has been validated in other studies. And the second one is to see if we can use this questionnaire in our routine practices by our local urologic surgeons. So this was a prospective study. It started in April 2024 to April 2025, and it was a quantitative study. And we obtained an ERB from the University of Rwanda, CHUK, CHUB, and King Faisal. And in total, we had 100 patients, where 9 of them didn't consent for participation, didn't participate in the study. 10 of them were lost for follow-up, and we were able to survey 81 patients, and I used the stats software in the data analysis. Going to the results, starting with the descriptive results, the mean age of patients at time of surgery were 44 years of age, and the time to surgery, from diagnosis to surgery, was 269 days, and the most common cause of the urethral stricture was found to be infection, which accounted 40%, and was followed by idiopathic, 23%, followed by iatrogenic, 20%, and lastly, trauma, which was 17%. And on the regression modeling, post-op patient who developed post-op complications, they had poor urinary quality of life, and they had significantly, they were not satisfied with urination postoperatively, and those patients who had post-op complications, they were worried about peeing, and they had very weak stream after surgery. And comparing two groups, one who had idiopathic urethral strictures from the traumatic urethral strictures, those with traumatic, they were significantly less likely to report a major improvement after surgery, and there was a significant association between the stricture location, the type of reconstruction like EPA or backhoe, and perceived urinary improvement. And there was a significant positive linear correlation between patient perception on their improvement, on their urinary improvement, and after the surgery, and this was correlating well with the quality of erection and ejaculation. On the second survey, which was shared among the local urologists and senior residents, we wanted to see if this questionnaire can be accepted or can be adapted in our routine practices, and 62% of them who responded to the questionnaire, they had an experience of 5 to 10 years of urology experience, and 46% rated the questionnaire to be clear, and 54% rated it to be relevant to be used, and 46% of the respondents found the questionnaire to be manageable, to be used in our routine practices, and it would take less than 10 minutes to fill it up, and 62% of the respondents say that they do not usually use the patient-reported outcomes questionnaires, and 92% of the respondents recommended to adopt this USSIM in our routine practice. So as a conclusion, urethroplasty has significantly improved urinary symptoms and quality of life, and this USSIM questionnaire can be used or is acceptable in our routine practice. Thank you for your kind attention.
Thank you, Dr. Kremans, for a very good talk, very nice slides. I knew the chief resident was going to be on time. Yeah, exactly. So we have the next talk from Dr. Tegekimana from the Rwanda Biomedical Center. He's going to tell us about the OBGYN nightmare of a urologist on call. At least locally, every urologist who is on call, he's expecting a call from maternity all the time. Like OBGYN is going to call you at any time. So you can't have a glass of wine because you are waiting for them to call you. So he conducted a study about that to look at the injuries that happen in OBGYN. That was before he joins the Rwanda Biomedical Center, where he's now involved into cancer. So today was double blade for him. So we're talking about cancer, but he also has a study that we include in this talk. It's going to be amazing. Thank you very much for being here.
Thank you so much. Thank you. You have talked about every resident on call. He or she must expect a call from OBGY. because of different reasons that I'm going to show you here. So we did this study. It's about urological complications following OB/GYN surgery. It was a retrospective study that we conducted at Seashika. As you know, a female urogenital tract are in close proximity to one to another. So the injury for one, it is almost possible. So when you are operating, you need to be to consider those possible complications. And those injuries can lead to morbidity or fistula and also possible renal loss. Our study aimed to determine the incidence, the risks, management options, as well as the outcome of those urologic injuries caused by surgery in obstetrics and gynae at Seashika. Our study was a descriptive, retrospective cross-sectional study that reviewed the medical files from 2010 up to 2018. And we conducted this for all patients who underwent surgery in OB/GYN department and also who developed iatrogenic urological injuries. So we described them by surgical approaches, causative illnesses or the indications, as well as management and the outcomes. So as I said, the study was descriptive, and so we described the findings in frequency and percentages. In total, during that period, about 13,000 surgeries, major surgeries were performed during that 8-year period. And among all 89 cases had iatrogenic urological injuries. The most injuries that was recorded was vesicovaginal fistula, followed by the bladder, followed by ureters, and sometimes ureters and bladders were injured at the same time. We found that most cases were diagnosed post-operatively. Others were also diagnosed intraoperatively. So post-operatively means when the patient was just taken out from the operating room, they found some signs and symptoms that they thought about those injuries and they go back to operate. As most operators who performed those injuries, most of them were done by general practitioners. As you know, Seashika is a referral hospital, so most complicated cases were referred from the hospitals. And in the district hospitals, that's where we have most general practitioners. That's why you see most of the cases were operated by general practitioners. But also we found other cases that were operated or where a gynecologist were involved, and some few cases by a resident. The main indications for the indication that relates to those urological injuries, most of them were cesarean sections, and followed by total abdominal hysterectomy, and very few with vaginal hysterectomy and other operations like myomectomy. The indications for those operations, most of them were due to uterine rupture. So when you're talking about the residents or our seniors, most of them, they had chance to operate on those women to do cesarean sections. You can understand when there is uterine rupture, what can happen. Others were operated due to abnormal labor. Others were having previous uterine scar, but also others were having some uterine prolapse. The most injuries, as I said, about ureteric injuries, and as the management option, most of cases were managed by double G stent. Others, they needed some repairs and reimplantations. For the bladder injuries, of course, they did primary repairs. Yes, that was mixed. For those who had VVF, they did primary repair. As the outcome for all those cases, most of them healed with no sequela. So sequela, we defined it as having further interventions due to those injuries. For example, those cases whom we call the healed with injuries, they ended up by having total abdominal hysterectomy. Others, they were having recurrent VVF, vesicovaginal fistula. So among those cases, we found 3 deaths. Others 2, we didn't find any records about the outcome for them. So we found that the iatrogenic urological injuries, it has a huge impact on the lives of women. So to identify them earlier, it is of paramount. And also having surgical techniques, good surgical techniques for those operators, it is needed. We recommend that we need to train those healthcare providers, starting from the nurses, on the potential risks so that they can act earlier. For example, if they have those cases who have uterine rupture, they need to care about it. Those who are having abnormal labor, they need to think about that. And also, we recommend that to include a rotation for OBGY residents so that they can have a rotation in surgery to get some skills, surgical skills, so that they can do good operations. Thank you so much.
Thank you very much. Our next presenter is going to be Patience Mukundirukuri. She's from the University of Medical School of Gaizo in the United States. She's going to take us through about the challenges that we get with urethral catheterization, the people's knowledge about, we think it's very simple, but I remember one study that I read from Dr. Bonane, which showed that most of our patients with urethral strictures were coming from iatrogenic injuries from the bladder catheterization. So she conducted a survey to look at how people are doing this and their knowledge about it. I'll be happy to have the insights from the survey. Thank you very much. Welcome.
Thank you so much, Dr. Theophile. My talk will be really brief. It's basically about urethral catheterization. Oh, sorry. Just give me a second. Yes, my study is about urethral catheterization. So I did this study alongside Dr. Edward Yindahio, and I'm a student, well, an incoming medical student at Gaizo School of Medicine. So why did we do this study? Okay, yeah, so urethral catheterization is one of the procedures that's done by nurses and doctors, and usually this is done because of urinary retention. It could be due to BPH or even urethral strictures, but in our case, we looked at urethral catheterization first of all, and then we looked at suprapubic catheterization as well, because suprapubic catheterization, usually when urethral catheterization is complicated, it can lead to suprapubic catheterization if maybe there's a stricture, and then you can do urethral catheterization. So that's why we looked at both. And usually when we do urethral catheterization or suprapubic catheterization improperly, we can have serious complications that can range from bleeding at first and formation of strictures eventually. So our problem statement was to look at just basically the knowledge and skills of healthcare providers in doing the 2 procedures. And we also looked at the availability of materials at the 2 hospitals that we worked with. So the study sites for our study were Kibungo Level 2 Teaching Hospital and Kiwia Referral Hospital. We also wanted to do King Faisal Hospital, but we are still waiting for the IRB approval from them. And we focused on nurses and doctors from the accidents and emergency, the surgical and medical wards, and the operating theaters. And we selected the 3 because those are usually the healthcare providers that usually encounter the urological patients in their practice. So that's why we selected those healthcare providers. So the methods for our study, so this is basically part of a very, very big study that we're hoping to do, which we're basically hoping to look at the knowledge gaps in the knowledge of nurses and doctors, and arrange or organize a training that's based on that, on the identified gaps, and then do a post-intervention study. But in my presentation, I'm going to be talking about the pre-intervention phase, which is basically the survey phase that we did. And what we basically did is we had a questionnaire. So we had a questionnaire that had 5 different sections. The first section, of course, was participant identification, and then knowledge, technical knowledge evaluation, and then practical experience and self-assessment, and then recommendations. So the recommendation section was basically allowed, like we basically gave people an opportunity to give us opinions on what they think should be improved in catheter care in men, basically, because we were focused on men, because as my colleague said previously, the men urethra usually is torturous and it's really long, and catheterization for men usually proves to be difficult because of that reason. So we used anonymous questionnaires, and they were both in English and French, and basically according to whatever the nurse or the doctor preferred, we would administer the questionnaire, and it was a cross-sectional survey. So for data analysis, I used Gemovi 2.4. And yes, for the material assessment, like I said, we had a list of the materials that you have for you to conduct a proper catheterization procedure. And we basically went to the pharmacy and the emergency department of the 2 hospitals that we went to, and we would check, say like, okay, do you have normal saline check? Do you have lubricant check? Do you have, you know, like we had a checklist that we were just basically checking off for the materials. So as for the results, we had 91 respondents, and the majority of them were nurses, and there was a very even split, almost even split between the 2 study sites, because at Kibungo we had 52% participant, and at Chibuye we had 47% of the participants. So for the qualifications, as you can see, the majority were basically the nurses, and the majority were above A1 and A1. So A1 and above, as well as A1. And we didn't get as many doctors, but the majority were residents as well. For the materials, I'll start with the materials, and then I'll go to the meat of the presentation, which is basically the other part that we did, which is not the materials. But for the materials, as I told you, we had a checklist that we were checking off, and Chibungo had pretty much everything that was required. But Chibuya was an interesting case because, well, they did have a lubricant, but it was not sterile. So they had a KY gel, but it was not sterile. So they would use that, or maybe use like UV gel. So that was a very interesting case. But I will talk about that more in the results. So for the technical knowledge, as I say, this is the first section that we looked at. Basically, what you see is a score. So we scored the questionnaires that we administered to the healthcare participants out of 11. So there were 11 questions that they could be scored on. Basically, did you get this question right? Did you get this question wrong? And so we added up the scores for the participants that we had, and then that's the average that you're seeing, the mean. Yes, that's me. And then, so when we looked at the means for both Chibungo and Chibuye, there was a normal significant difference in the score, but not very significant. So for the reported confidence, this was basically a chance for the healthcare provider to tell us what they think they're capable of doing. Say, for instance, like, do you think you're really good at doing catheterization or not? So you would rate your confidence on a scale of, well, very confident, excellent, to like not very confident, or I doubt my skills. So when we evaluated this, we saw that the majority, which was 80%, reported that they were very excellent at doing catheterization, or that they were very good. But when we analyzed the results later, which, well, we scored them, like I said, 91% scored below the threshold. So how did we set this threshold? So we had a score out of 11, and then we looked through the questions, and we were basically like, okay, if you get this question wrong, does this necessarily mean that you're not good at doing the procedure, or is it just like general knowledge? So we identified 2 questions that were not very reflective of, well, the overall knowledge, and then that was set to 9 out of 10, no, 9 out of 11. So we basically scored everyone, and then we looked at everyone who scored below 9 and above 9, and 91% scored below 9. And that's interesting because, well, everybody said they were confident, so that's a very interesting find. So again, we also had a question that looked at the lubricant used, specifically the sterile lubricant used, and 69.3% reported that they have never used a lubricant in their performance of the procedure, and that's very alarming. And 44% say that they used to use normal saline, so that's very concerning, given that we know that this is supposed to be an aseptic procedure, and seeing somebody perform this procedure with just normal saline is very concerning. Well, I did not even talk about the, you know, the UV, not the ultrasound gel, no, because that's also very concerning. But normal saline really stood out to us with the 44%. And so why does this matter? So we also had a question that looked at, well, it was basically asking the healthcare provider to say if they've ever seen a patient show up at a clinic with a visible urethral collection bag or urine collection bag. And 62%, well, more like 63%, say they have seen a patient with a collection bag visible. And you can only imagine if somebody is seeing a patient show up to a hospital with a urine bag very visible to everyone, you can only imagine what's going on in the mind of the patient, right? Like, they're showing up, everybody knows they have issues with urination, everybody knows they have a catheter and all. So it's very concerning because there's a lot of people who are living like that in our community, and it's basically like, it just reflects the level of education, patient education that we're giving as healthcare providers. So what are the future directions? Like I said, this is part of a really, really big study that we're hoping to do, where we're hoping to train people on how to perform urethral and suprapubic catheterization really well. So having seen all of these results that I showed you before, we're hoping to, based on these knowledge gaps that we've evaluated, basically the use of lubricant or even the knowledge, just general knowledge, we're hoping to do a deeper dive into the questions that we asked, and then we're going to design a training that's based on those results. So by doing this, we're hoping to improve the healthcare provision in urological care in general, not only in the 3 hospitals that we decided to go with, because we chose the 3 hospitals because they're training hospitals for AHUSU students, but we're hoping to also get to other hospitals that are not the AHUSU training centers as well. So that's basically, oh yes. So yeah, so like I said, again, this is a repeat of what I said previously, because this is a pre-intervention phase that we're doing, and we're just hoping to, based on it, to do a broader study in the future. Thank you.
Thank you. It's very concerning. Somebody has never used the lubricant to do their urethral catheterization. It's a big problem. I can imagine. Dr. Edward, you've been part of this study. I want to ask you a question. Do you think we should get this urethral catheterization procedure to doctors only? Do you keep it delegated to the nurses, but we not have enough urologists or residents to put catheter to everybody who needs a catheter? What's your take? What are your recommendations after the preliminary data?
Thank you, Theo, and thank you, Patience, for this great work. Patience is not yet at medical school. She's a pre-medical student. But maybe in my next presentation, I will talk about her more. So my comment is that after these results, I took a 14 urethral catheter, I put some lubricant, I catheterized myself 1.5 centimeters to feel what patients feel. It's horrible. I did that because there was an old pediatrician who used to tell us, test the drugs you give to children you'll feel what they feel. So in summary, I want to bring attention to the audience. The small things are not as simple as we think, and we have to advocate. This proposal was given to, searched for funding, we couldn't find, because our diseases are not known to people. When you talk about urethral stricture, it doesn't go to maternal and child health. It doesn't go to cancer. It doesn't go to NCDs. Does it go? No one talk about these strictures, these problems that are caused by urethral catheterization. So, in summary, I have nothing to add. The data talk. We need funding and train and explore more and train people. Thank you.
Thank you very much. Yes, sir.
The question I want to ask patients, why there is no sterile lubricant in the hospital? Is it because the people don't know they are supposed to use it, or is it because it is not available? Because these are, before we move to answering who should be doing the catheterization, all over the world, the nursing, it's a nursing procedure. So why don't we have lubricants? Why do we have a catheter and we don't have lubricant? Maybe people are not requesting it.
Thank you, Prof. You want to have a say?
Yeah, thank you so much for a very good question, because basically that's what we were wondering as well. After seeing all of this data, we were like, what's going on in our healthcare system? So we had a talk with the pharmacists and the healthcare providers that we got a chance to meet on our survey phase when we were away, and then we asked them, and some pharmacists were like, oh, okay. So one interesting case was they had KY gel, but it was not sterile. So when we asked them, they were like, oh, we didn't know there was a sterile KY gel. Like we never knew. They just gave us this and we used this. So we have no other choice. And then when we asked the healthcare providers as well, like the same question, they were like, okay, we just use what's available. We know we're supposed to use the sterile materials, but sometimes we're not provided the materials at the time, and we just use whatever we can find and hope for the best. And then some other times it was just pure, they did not know that they needed a sterile KY gel or any other gel. So it was a very interesting find for sure, but it just pointed us towards kind of exploring that in further, just finding out who knows what and who doesn't know what, just to know how to address the key root, the root cause of the issue that we're seeing in our patient population. I don't know if Edward has something to add on what I just said, I guess.
Okay, thank you very much for your answer. Dr. Bonani wants to say, but he will be the last one to say something, then we probably go for lunch.
Thank you. I am not going to say much, but I am going to shock you even further. Because just yesterday, I prescribed KY gel for a patient. The patient went to the pharmacy and they said it is not covered by the insurance. So this means we have to fight the fronts along the two ways. The hospitals to stock the KY and also the insurance to reimburse the KY. Thank you.
So the challenges are very compound. So it's going to be not only the administration, not only the healthcare professionals, but it's going to be also part of the health care insurance. We are going to have a panel with Dr. Nwari, who is from public health insurance. So we're probably going to ask all of these questions to him. say.
Thank you for raising this issue. I know that we have many criteria during verification. Most of the time we cut money for the hospital because of A, B, C, and D. But let me tell you one thing. The current costing is bundled. It means when we think about electrocatheterization, we added on the procedure all the consumable that are needed inside. That means we can't build a procedure where the consumable are already inside and also go and bill the consumable outside. It's like a double billing. That's why it's refused. It doesn't mean this KY gel which is there is not authorized. Yeah, I think you have to first to check on the new criteria of billing.
Thank you. We'll look into that and maybe try to explore that further with the details. Thank you very much for it is a new bundling and a way of paying the new tariffs. Still challenging and okay. Thank you very much for your insights.
I think we have to recommend something. Otherwise, we shall keeping torturing our patients. Since you know the payment is bundled, I think the hospitals, the health centers, they should not buy urethral catheters only. They should ensure that urethral catheters come with sterile lubricant. I think this is the message that we have to give to institutions.
Thank you very much. We try to consider that, and we also, whenever we have issues, we're going to be coming back to you, because sometimes the patients needs to get the catheters and the KY gel at home to do like CICs. These are maybe special cases, and we discuss and say that. Sure, not audit, but thank you. I would like to invite everybody for lunch. I hope everybody has received a paper for a paper like this. If somebody has not got it, there's a young girl who's distributing these papers, and that's what we use to get lunch outside. And then we're going to come back after 20 minutes maximum to have our next time. Okay, let's come back at exactly 3 p.m. and then we start the next session. We are so much behind the schedule, trying to catch up. Thank you very much.
was wondering if there was discussing about lubricant, which should be containing lignocaine. Then I was wondering, in all hospital, we don't have a small which we can use for one patient and it's over. It's for the people who has a small one, it's one, which you can use for 10 patients after opening. So I was like going to give a recommendation for the people who are looking for us, government, RBC, Mutuelle de Santé, if you can have a kit for catheterization. That kit will have like a small lubricant solution, the water for injection, and another solution for cleaning. It's small. Then gloves, sterile gloves, and even a drape. So even those people who are familiar with routine, I don't think they will do the routine while they have everything on table. Thank you.
Thank you very much for your recommendations. Point taken. We try to advocate and see if that can be implemented. It sounds like feasible and is being done elsewhere. We shouldn't be having difficulties doing that. So we are going to have a panel discussion right now. It's going to be a very short discussion. Prof, I'm very sorry. I think I don't have the right words to introduce you. Dr. Maxime said before, like he's the Marshal of urology in Rwanda. So I totally believe in that. Prof. Emile Rwamasirabo has been a pioneer to urology in Rwanda. I like his quality that he introduced in this country. All other pioneers and senior doctors, when they go in their country, they know they have the skill. They keep it for themselves so that they can make money and be the only ones who are making story the whole country. But he decided to start a program. He decided to teach everybody, and that's why we are here as urologists. If he wasn't there, we probably wouldn't be here as urologists right now. Thank you very much for doing that. Now, I wish to have you on the panel for discussion now, but I will not say more things, because I can talk about you for probably 1 more hour, and it wouldn't be it. I would like to also welcome Dr. Ndize Ntwari, who is here as a representative of the RSSB. And he's going to be on the panel. Dr. Ntwari has been, is a gynecologist and obstetric specialist with a vast experience in clinical practice in healthcare management and health project implementation. He has led both public and private health institutions in Rwanda and served as a country representative for IntraHealth International. And currently he is the head of medical advisory department at the RSSB, where he focuses on improving patient safety, clinical quality, and healthcare delivery. Please give him a round of applause. Welcome. My next panelist is going to be Dr. Bonane, Alex Bonane, one of the elders in urology in this country, and he's a true surgeon educator in this country. He's head of undergraduate medical student education in the surgery department at the University of Rwanda, and he's also a urological surgeon at CHUK, and he has been contributing a lot of work and publications in when we talk about genitourinary injuries and trauma in general in surgery. Welcome, Dr. Bond. Please give him a round of applause. Thank you very much. We decided to shift this session early because we have trying to rearrange the agendas because we have virtual presenters from the United States. So we want to try to fit in their times. So if you see the agenda being flipped, that's why. Thank you very much for being here with us. I want to... So we're going to discuss a theme called strengthening diagnostic modalities and access to care and financing of trauma and avoiding dysfunction in low resourced settings. I will start with Prof. Emil Ramasirabo. If you look at the current state where we are right now, what do you think we need to modify to have a better access to the diagnostic modalities and to care to the patients that are in primary health care? Is there a possibility of having cost-effective diagnostic tools that we can have at the district hospital levels that are going to be accurate and giving accurate diagnosis, but also keeping the cost in acceptable ranges? The floor is yours, Prof.
Thank you, Theo. I'm going to be a little bit provocative. I don't think we need so many tools to diagnose lower urinary tract symptoms in district hospitals. I think in the old days, I don't know whether it is still true, we used to say that lower urinary tract symptoms can be diagnosed by good history taking and physical examination. 80% of cases could be diagnosed appropriately, and then cases would be referred. But if you look at patients that present at primary health care facilities complaining of lower urinary tract symptoms, the biggest difficulties we have is because the people that are operating at that level do not have a proper basic urological training. Basic medical training meaning the symptoms. They don't know how to interpret the symptoms. When you look at, for example, the cases as they are reported in the HMIS, which is the Health Information Management Systems, all those cases are reported as urinary tract infections. And indeed, when you look at the data in HMIS, you'll find very high numbers of urinary tract symptoms, urinary tract infections, which you don't see in the day-to-day hospital. You don't see those cases. So, and I'm sure also, even my colleague on the right, who is a gynecologist, will be surprised to see how many cases of urinary tract infections that are reported in prenatal consultation. which they are not, I mean, there are some urinary tract infection, but not as many as there are. So I think what really we need to do as Urological Association is training the primary health care providers on how to manage these cases. If a patient has urinary tract symptoms, it is possible to recognize them and refer them without delay. Either somebody has a poor stream, that's not very difficult. You know, I'm sure you know, maybe you don't know. In the old pictures, you know, the British doctors in Kampala used to put patients on one line and make them pee, and they would have graduated, you know, and they would determine whether patient had difficulty. The poor stream was kind of colonial Euroflometer. So you'd see pictures of 10 men peeing at the same time to see who would go the farthest. I'm not advocating for that, but what I'm saying is it would not be difficult for the providers at the primary health care to know if somebody is not passing urine well, if somebody is having pain at passing urine. So I don't think the difficulties to diagnose patients is really to do with equipment. Now, what to do, I think, is to continue training, capacity building of primary health care practitioners. Most of the facilities are health centers. We have about 500 health centers in the country, and more than 80% of our patients in Rwanda are seen in the healthcare. So the patients presenting with lower urinary tract symptoms, most probably that's where they should be. So, and these health centers are managed by nurses. So meaning that training, capacity building should go down there. Health centers are supervised by district hospitals. Hospital in the district go every month, visit health centers in their catchment areas. You all know it because most of you went through the system. And this is the kind of message you should provide to district hospitals, the doctors in district hospitals, provided that they have been also been trained appropriately to recognize these symptoms and the signs. There is one case in point. When we are conducting the entry examination for the residency last year, we asked one of the candidates, if you see a young man with acute pain in the scrotum, sudden pain in the scrotum, what are you going to do? He said, I'm going to refer. What do you think it is? He said is most probably a testicular torsion. So where are you going to refer? The nearest place is about 4 or 5 hours. So don't you think you should do something? Otherwise, this testicle is going to die. He said, well, that's how we do it. So do you think we should be referring testicular torsions from a district hospital to a referral hospital? I don't think so. So so GPs working in district hospitals should be made capable of managing an acute scrotal torsion. So meaning that the issues really can be handled at minimal costs. If the provider are able to recognize, interpret the signs and the symptoms and the sign and the refer, I think most of the cases would be handled appropriately. Now, in the referral hospitals, there are a few cases that require investigations, such as, of course, urethral opacification. I take it for granted that these are normally covered by insurances. Shouldn't be a problem. So there may be issues with urodynamics. The urodynamics, the catheters pose a problem. You can see Florence entering. She's always complaining of UDS catheters. I don't know if it's still a problem. Is it still a problem? Yeah. So surely, I think the insurances should understand why sometimes we need, in a few cases, we need really to do those investigations. And it's not something that you can bundle in anything, because you need the catheters to examine the bladder. Not in many cases even. There are few cases. Otherwise, I don't think there is any challenging procedure that is would be so costly that we are not able to overcome. So it's the question of talking to the right people and also the right people to make the decision. Thank you very much.
Thank you very much, Prof. I will probably go straight to Dr. Nwari. You evoked about this kind of consumables that we need to conduct ample investigation before the patients can get surgery, like UDS catheters. They are very expensive, and if you couple it in whatever cost for the UDS, it won't be probably possible because they are quite expensive. But I'm aware that we still have a room of writing and get it approved at the insurance level, and then we can add it. He will probably say something about that. He would probably want to tell me, we had a talk before about iatrogenic injuries in obstetric and gynecology department in Sashuka. Do you think there are policies that can be made to prevent this kind of injuries? Because most of the patients that were operated at Sashuka were not necessarily from Sashuka. They were transfers from district hospitals and all that. Which solutions do you propose at your insurance level? How do you propagate this information to the people down in the community that they can be aware and prevent these injuries and be helpful to the patients, so to prevent morbidities to the patients? Please go ahead.
Thank you. One question is about the reimbursement, and another one is about how to support accessibility of healthcare.
Yeah.
First, thank you for inviting us to come and discuss with you. This kind of discussion is better. It helps us to understand each other concerns. As you are saying, Mutuelle de Santé is a fund where there are contributions from patients, from population. There are also contributions from the government, from other health insurance, from traffic fines. The traffic fine also contribute in the mutual. Today we are trying to develop the benefit package of patients who are using mutual as an insurance. Developing the benefit package for the mutual, it's a long process because there are many priorities which are not yet covered by mutual. It means to assess any new technology or any new benefit, it requires that benefit to be first assessed, so we can be sure that by implementing these benefits, it will not collapse the insurance. Yeah. So far, we have moved to ensure that all life-saving situations are covered, because starting July, we started reimbursing like dialysis. Before, we were not able to reimburse dialysis. We started also reimburse the management of some cancers, almost many cancers. We also started reimbursing arthroplasty. All these services, we started reimbursing them since July. We expect to increase our package, but all depends to the increase also of the funds. Yeah. The other way for us to make sure that we are getting the mutual increasing in coverage of service is the way to manage that fund also. Why do I insist on this? It's because there are some expenditure which really will not be needed if we all understand each other that this contribution need to be managed by not only the insurance, but also the health practitioners. Because when we go through many claims we receive for reimbursement, you will see many waste inside. When I say waste, I can give you many things to consider. Like there is an hospital where I goes once. Systematically, everyone who came for elective surgery, they have to do all the renal panel, they have to do hormonal panel, they have to do glycemia panel, they have to do all the exams they can handle in the facility. You know, with that kind of attitude, it's like we are wasting the money for something which will not contribute to the outcome of the patient. That means on my side also, I would like to invite all of you practitioners to help us in the management of that fund so we can reduce the waste for that. For the aerodynamic, the first time I hear about it's on this meeting. But we had discussion before with some of the colleagues, urologists. We know that we are facing challenge of new technology. It's coming every time. For us to make sure that we are able to reimburse it without compromising the sustainability of the mutual, we started to do what we call health technology assessment. It means any new technology which is introduced in the Rwandan health market, we have to do this assessment to ensure that with the budget we have, we will sustain if we reimburse this. We have also to ensure that this is a priority. So if we don't reimburse, there is ABC consequence to the patient. because today we want to make sure that all life-saving conditions are reimbursed, even disability conditions are also reimbursed. We are moving forward, and please let us know when you have any new technology that need to be reimbursed, which was not reimbursed before. We have just a template to share with you. You fill it, and on our side, we assess, and then we come back to you to see if this is really a priority to be reimbursed, or if this still needs any time to get more resource for it. That's the way we go through a review of all new technology. Exactly for the second question you asked me, maybe you ask me as a fistula surgeon, because I used to do that project before I joined the insurance.
Yeah.
Yeah, it's a challenging, as you are saying, because most of the cases we used to operate on were all in the community, hopeless, without knowing where they can receive a treatment. Because the question I was asking myself was how someone can spend more than. I remember I used to operate on a woman who had her fistula in 1964, 14 years before I was born. And she was somewhere in the community. And our approach was to call people to find us the place where we are going to do surgery. And once we didn't find any patient, so we changed strategy. We say, let's go at the district level. But before we reach there, we have to provide almost 2 weeks to community health workers to do sensitization. And the only symptom for the community health worker were to telling them that anyone who have a leaking have to consult. There will be specialists who will come on this period. Let me tell you the experience. Really was finding some people who have a problem of fistula, but the case of advanced cancer were more, cervical cancer, they were more. And most of them, they didn't even realize that they have cancer. What I can suggest, and which is my suggestion, we should know how to face our care. We succeed with HIV because the management of HIV started at the community level. At the community level, they know what to do. At the health center level, they know what to do in the management. At the district level, they know what to do till the referral level. I think if we go through fistula, just tell the community health workers to identify any person who have vaginal leakage. You will find many people who will be transferred to the health center. If you teach someone at the health center just to do a dye test to confirm there is a fistula, you will do more to identify more patients. Maybe the referral at the health center level, we reimburse. Our response most of the time is no, because we need to be sure that if we start paying this, we don't think about only the patients who are in front of us. We have to check about the patient in this which come in our mind when we want to authorize something. How will be the patient needs? If only starting reimburse this will cost in 1 year like 10 billion, it's not a decision of one medical doctor in the office at RSSB. It's something that needs to be reviewed by many people. That's why you'll see our response is tell the patient to write to the medical committee, because the medical committee will be the one to decide on this reimbursement, or completely this is not in our reimbursement package. And when we say this is not in our reimbursement package, I know that it's more costing for the patient, but if this is really needed, it will be the out of pocket of the patient. But we are trying our best to make sure that all life-saving conditions, all disability condition, we are able to make sure that we are reimbursing them. That's what we are trying to do. But on your side, any new technology you think need to be assessed, please don't hesitate. It's a simple format. We can even help you to feed it. So we can be sure that we give a response for the service instead of providing a response to one patient.
Thank you very much. A round of applause for you, please. Thank you very much. That leads me to ask to Dr. Bonane, who is heading the education of the medical students at the University of Rwanda in the surgical department, and has been contributing a lot into this for a long time. The first time I knew Bonane was when he was teaching me. So up to now, he's still a lecturer at the university, and he's very good at it. All of the students love him, I'm very sure. Dr. Bonane, both of the doctors next to you spoke about educating and sensitizing the community to come to the hospital to get healthcare. But we have a good numbers of doctors that we have increased already in the hospitals right now. But we still see the patients that come to the hospital after 10 years, after 15 years. Was it last year we operated on a patient who had been going to a district hospital to change his suprapubic tube for 15 years. And for him, he believed that was enough and is going to heal one day, like there will be one day that was going to be healed spontaneously. And the sad part of it is that some of the general practitioners had met this patient. Saw him a couple of times for UTI, for changing the suprapubic tube. And what do you think we need to do in terms of education and improving the education partners to our students, so that when they go to the community, they can be picking up these injuries and the surgery services that follows the injuries? What modalities have been working for you to effectively educate the medical students, and what do we need to improve, and what have we been not doing right? Thank you.
Thank you. Thank you for giving me this opportunity. Talk about the training. Talk about the training and maybe correlate it and link it with the patient care. So for both of these fields, the training as well as the patient care, I think I have been in it or in them for quite a long time, and the experience I have in them should be sound. So with the training, if I immediately move it with the patient care, the people that we train in the medical school, with regard to the levels of health care, go as far as the district hospital. Below the district hospital are also other levels. There is a health center, there is community. So they are at the level of the community and also at the level of the health center, they are health levels. These are health levels. So these students that we train and immediately allocate them or send them for the service in these levels. Of course, they have some limitations, but they have a good package. So at each level, there is a package. And somebody who is there at that level, he should be or is supposed to be knowing what is done at that level. But of course, training doesn't stop. Training continues. Training, somebody is gaining knowledge, is gaining skills all the time. What I must accept is that with regard to the health pathways, with regard to the referral pathways, there might be some gap to these people that we send there after graduation. So what I'm saying is, most of these people who are coming late are not, most of them are not coming late because they reached the district hospital and they failed to be referred. In fact, the big number delays before reaching the district hospital. So what I'm saying is, we should go to the level of the community, because at the level of the community, they are community health workers. So these ones, we also work with them, we train them, we tell them what we want. This one I am basing on the fact that at one time, when we moved down to the district hospital, because we had communicated to the healthcare workers, all the people, I cannot say all the people, but most of the people, over 90% I'm sure, had been mobilized and they met us at the district hospital. So what I'm emphasizing is, we go to the level of the community, educate. Of course, the Minister of Health has these people there. But what we are going to do is to go and tell them what we want. We tell them, we give them, of course, they are going to understand the symptoms, the signs of they are going to look for, because these community health workers have also catchment areas. One has maybe 5 houses or 10 houses. So the people in there, they know them. So they are going to be able to bring those people to the health center, and from the health center, they come to a district hospital. After they have reached the district hospital, then we are going to be there, because this time we are dealing with people who have the potential. These people who are there, we go work with them, we train them more, we tell them, and we also empower them. We tell them that if you have the people with such a problems, do not hesitate. We communicate some sort of a link, some sort of a smooth pathway, some sort of, you show to them that you've already established your area and you want them to be sending you these people, because they are also not happy. When somebody comes today, he has nothing to do for the patient comes tomorrow, comes the other day. This doctor or this health personnel does not want that patient there, but is having challenges. If we empower him or her, then this patient, the moment he's seen, is going to be transferred, is going to be referred. That's what I'm talking about in that line. Then we have also to look at another corner. The facilities, the services that can be given at that level, the facilities should not show much. Because we are not going to say that you refer 100%, no. Those ones, that package that can be done at that level, let us put the materials, let us put the facilities, and then they be done there. Then those ones that cannot be done there, they get referred. In this case, the worker is going to be uniformly distributed and all the levels are going to be operational. But if this one is not done like this, then it blocks there on the way. So in summary, as my counterparts have been saying, the investigations, for example, at the district hospital, for a health personnel, for a doctor there, GP, who is at the district hospital, to diagnose somebody with urethral stricture, for example. They are not complicated and they even know. But what we need to do is, we also go, refresh them, tell them what we want, give them the potential, empower them, then we say that the materials are here, we've advocated for them, we've asked for them, the levels, for example, the Minister of Health and other levels that are responsible have put them there. For example, history taken at physical examination doesn't need anything. Catheterization, for example, to see if the catheter cannot pass and there is a stricture, that one can be done. But those materials, to do it safely, let them be there. Also, the investigations, for example, the cystourethrogram that we do here, there also it can be done. And this one is going to be even cheap, because when somebody does it at a level close there, it becomes cheaper, other than bringing them there when they can be done there. So let us make it like this. Reach all the levels, train them, facilitate them to do what they can do, and also empower them to refer where they cannot do. So with this uniformity, then the work is going to run effectively. I thank you.
Thank you very much for your valuable advice on how to get this challenge gone. Unless there is a burning question from the audience, mine were all that. I would probably give to Prof a minute to wrap up and say the last word. As a surgical educator, do you think we are ready, the system is ready to receive? If you go to the community and all people come to us with 14 urologists only in the whole country, we were joking at lunchtime, before lunchtime with someone, saying that if all the men that are beyond 45 years come to us for screening, are we ready to receive them? Actually, are we ready to see them all? Do you think we are ready to go to the community and call upon all the patients that need this care to come to the urology unit? What do you think? What do you need to be doing to get ready for this influx of patients, which has started to be overwhelming already in urology everywhere in the center? In Butare, when you do an outpatient, you know it's going to be so much, and at the same time, same thing in Kanombe and even in Sashwika. What do you think we need to be doing to increase this? Is the system that the government has laid of 4x4 going to work out, or what do you recommend?
I think what you're talking about is about the waiting lists, right? Waiting lists. We have waiting lists.
Both and the
in
patient
all
that comes.
hospitals.
Yeah. Waiting list and the patient that comes for outpatient consultations.
Yes. Most of the patients that come for consultation in referral hospitals, especially for these specialist care, and I'm sure those that are working, for example, Dr. Eve, I'm sure he sees all the same patients that keep coming. They keep coming, waiting for either for the prescription of medicine or just to be scheduled for surgery. So the problem of waiting lists is something that needs to be, in my opinion, need to be handled at national level. We can have a database of waiting lists and organize ourselves to operate these patients in a more organized way. We are happy to sometimes have these camps. These are the right way of doing it. We do it, we constitute a database and we organize, we schedule how to work on these patients. May it not be enough, but it's going to clear a big number. Now, there are issues to deal with medications. This is, I don't know whether the harmonization of RISSB has been carried out. We have patients that have to come to clinic every month to get their prescription. You see, this is something I have never understood. Well, these are people with, mostly people with BPH. You know, they have their BPH and they are going to have their BPH for many more years if they are not due for surgery. So these patients will need medication. So as RSSB, the most, for me, the most rational way of doing is to provide them even medication for 6 months, since they don't need to see a specialist really. But they need to see a specialist once or twice a year. They should be getting their medication for a long period and go home with their medication. It is cost effective even for RSSB, but even for the patient, most convenient for patient. This is something we really need to discuss with RSSB and find a way of dealing with it. Either the doctors, the health centers near the patient's location are allowed to prescribe, to give a maintenance prescription, so that they don't need to travel 300 kilometers to have a prescription for the same medication that they're going to be taking. And I think this can be sorted out. We're happy to have Dr. Lindsay here, who is going to, who have understood you. So take it up with him so that that issue is solved once for all. No point of coming to CHUB from Karongi every month to get a prescription. Does that make sense? So that's it. I don't know whether you were talking about training.
Yes, that's good already. Good insights.
Yes.
And
So with regard to training, you said that complex cases, injuries. I'm sure you are referring to pelvic crash injuries with that patient that spent 20 years. I think I also know him. 20 years with a suprapubic catheter. I think that guy has something in, and he lived in Kigali. He's been living in Kigali. He was even an educated man. But for some reason, he wanted his suprapubic tube. So it's not really not to do with not having access to care. But I know we have quite a number of those patients with crash injuries, with ruptured urethra in the community out there. But where are they? If, for example, somebody asks you today, how many of these cases do we have? Do we have them? We don't. So that's why we really need to have a database and work on them in an organized way. When we have a surgical camp, we get all these patients, we work on them on a regular basis. That's the only way. Otherwise, training of residents, training of young urologists in reconstructive surgery, it's something that needs to be taken as an agenda for this organization to ensure that we can manage all those cases in waiting list. So it is your duty as urologists, trainers, to keep this one on the agenda. You get people that are interested for further training. And I think you have to make it a priority. In any case, you saw the practice of urology is changing. It is the reconstructive surgery that's not changing very much. Otherwise, with more advancement in biomedical sciences, genomics, and molecular biology, you'll find no cancers to operate in the future. So you better make sure you are good at reconstructive surgery, which maybe, you could also have more development in stem cell technology, new tissues, but you still have to operate.
Sure.
So
that's definitely true.
Reconstructive surgery, put a lot of effort. Get more people that can get involved. Thank you.
Thank you very much, Prof. We are very happy to have you. Thank you. A round of applause for our panelists. Thank you very much for your insights. For the sake of time, you are heading to the next session. I would like to call in Dr. Emmanuel Muhawenimana to moderate the next session, where we're going to start with Dr. Kelvin Moses from Vanderbilt University. I think he's probably ready on Zoom. Please, because he wants to go to... Oh, welcome.
Hello, everyone. Can you hear me? Can you hear me? Yes. Yes.
Hello, Dr. Kelvin.
Hi.
We are very happy to
Okay,
to have you presenting today at the first symposium of the Rwanda Urological Association. So Dr. Calvin Moses is a surgeon from Vanderbilt University, and he's a uro-oncologist. So the floor is yours, Calvin.
thank you very much. I appreciate the invitation to speak from Dr. Teo. I wish I could be there. It's currently very cold and icy here, and I would much rather be in Rwanda. I want to thank Professor Edward and Professor Emile as well, who have been wonderful hosts and friends as we have traveled and worked in Rwanda many times. I will present my talk without slides. I really just want to make a few points for the topic of international partnerships in urologic oncology. I remember several years ago, probably the first time I came to Rwanda in 2018, we looked at the overview of the burden of prostate cancer and bladder cancer and other penile cancer in Rwanda and East Africa, and the need for care for the patients who are presenting with this, not only care for their disease, but then any sort of preventive or screening that we can do to lessen the burden of disease. When Professor Emile and Dr. Joseph Smith here from Vanderbilt first made acquaintances, I believe they both impressed upon each other the importance of partnerships between the major medical centers here in the U.S. and in East Africa, because it really is an exchange. The whole purpose of what International Volunteers of Urology and Dr. Smith specifically is that we from the U.S. may have lots of resources, but the knowledge and information are shared, and it is back and forth. I tell our residents when we bring them that they will be impressed and probably a little bit put to shame how much more the Rwandan physicians will know, because that information is critical. And sometimes when you don't have every resource, it's knowing that information is most important, so that when you do get the resources, you can put it in place. The other thing that Dr. Smith and many others have emphasized, and is really what I feel is our most important role, is not to be surgical missionaries, in that you show up, do surgeries, and then leave, but rather to be surgical emissaries, in that our role is to help with teaching, to help with skills building, to help with designing a program so that it becomes self-sustaining in our absence, and helps with patient continuity and care down the road. Each of the urologic oncology camps that we have done with the leadership of Professor Edward, we've always had a specific focus where we have a certain set of patients with similar conditions, so that we can do similar cases over and over and help with skills dissemination, but also to do lectures that are presented by the home team, as well as lectures that we present with some of the cutting edge. And then also to help with refining and advancing research that is being done locally. Again, all for the benefit of the patients and for the trainees. I have used the Rwanda model as an example for other places, including I just recently went to Uganda and met with several of the surgeons there for a camp. Again, as a model for developing a residency training program, a model for and the Rwanda Health Ministry sending the trainees to all parts of the country with centralization in Kigali, so that even advanced and complicated care can be accomplished. I'm very proud of my association with the University of Rwanda and KFH. And I'm very proud now that others have joined in with this effort, specifically Dr. Harold and Dr. Salami, who are two of the bright young stars in urologic oncology and health services here in the U.S. Dr. Harrell and I go way back. She trained where I trained, and she was my intern, and I've seen her grow from a baby doctor to completely surpassing anything I've ever done, and really just what we would call not even a rising star now. She's in the sky. And same with Dr. Salami. He reached out to me early in his training, and now is really just a nationally, internationally recognized surgeon. So I'm hoping that they are enjoying their time there and enjoying the cases. As many of you know, we met with the Rwandan Health Ministry when I was there last April, and we are now developing a urologic oncology fellowship / certification for the surgeons there in Rwanda. And this will be done in collaboration with Vanderbilt University Medical Center, where I am, as well as University of Michigan, being represented by Dr. Salami and Dr. Harrell. And others who I will bring in subsequent camps, all being sort of assisted and overseen with IVU, International Volunteers of Urology, who help us with coordination. I've spoken with Professor Edward many times. He came and visited us a little bit over a year and a half ago. The entire goal is to make a pipeline for those interested in urologic oncology who can complete their entire training there, but also incorporate visits with University of Michigan, Vanderbilt, or wherever we can get them to come. But is to develop an entire program to help with the goal for prostate cancer screening, to decrease the burden of advanced disease in the country, to incorporate total care for bladder cancer, all the way from intravesical therapy to radical cystectomy, to incorporate minimally invasive care, laparoscopic surgery, and then develop a curriculum so that we're meeting on a regular basis, presenting cases, doing lectures, doing morbidity and mortality conference, and any educational efforts. And again, just to go back to my original point, the entire impetus for what we are doing is educational exchange, skills development, and propagation in perpetuity whenever I fall off the face of the earth or whatever, so that these things can go on. I'll go ahead and wrap up. I do need to go to the operating room, but again, thank you very much, Teo, for organizing this meeting. I think this is just a tremendous effort. Professor Edward and Professor Emile and everyone who is there, Professor Africa, all those who I've met over the years. I truly am humbled and honored to participate with all of you, and I look forward to seeing you in the future. Thank you very much, and happy to answer any questions.
Thank you, Moses. Do we have any burning question to him before he goes to the theater? One? Moses?
Yes, I'm here.
All right. Edward has something to...
Mine is not a question. Thank you so much, Professor Moses. We appreciate the great work you've been doing here and your collaboration with your countrymates who are here and who are also supporting us. So just wanted to thank you and to tell you that we presented the preliminary results of what we have been doing since you started with us, and then we want to write a paper on that. We have 38 cases of radical prostatectomy, and we'll share soon for the paper to come out. Another thing I would like to communicate to you is that yesterday I went with the team from here and the team from Michigan, and we presented the draft of our fellowship in uro-oncology, and it was approved, and it has to pass through different levels of University of Rwanda. Hopefully within next 6 months we can start. So I thank you so much, and I hope to see you soon again. Thank you.
Thank you very much, Professor Edward. Really appreciate those kind words.
All right, thank you, Professor Moses. I think we'll let you go now to your duties.
Okay, thank you. Everybody have a wonderful day.
So our next speaker will be Dr. Jen Kurtzman. She's an assistant professor of genitourinary reconstructive surgery at the University of Utah. So Jen has been she's a member of GeoImpact, who are our partners in reconstructive urology in Rwanda. They have been with us for the last 12 years, 14, on this journey of reconstructive urology. And she's going to talk about the evolution and impact of IVU-Med GeoImpact partnership with the Rwanda Urological Association. Jen? Do you hear us?
Hi. Yes, hi. I do. Hi, everyone. Thanks for having me. I'm just going to share my screen. Bear with me for a second. Let's see. Share. It's this one. Okay. Can you guys see my slides?
Yes.
Does it look normal? Like it's taking up the whole thing, or is it in presenter view?
It's perfect.
Okay, great. Well, thank you so much for the introduction. I'm so excited to have been invited to be a part of today, and congratulations for everyone for putting this on today. So as Dr. Emmanuel just mentioned, I'm going to be giving a talk today on the evolution and impact of the IVU-Med and GeoImpact's partnership with the Rwanda Urological Association. And before I get started, I just want to say a special thanks to a couple of people in particular. I have a hard time with all of your last names. So Dr. Edouard, Dr. Emmanuel, Dr. Theo, and Professor Emile for your kindness, support, collaboration, everything since the moment that we all started working together. So I'm really excited for where we've been and where we're going. And I'm going to tell everyone a little bit about it today. So for those of you who don't know me or know where I'm talking to you from today, I'm phoning in from Utah, which is in sort of the western portion of the United States. That picture on the right side of the screen is a picture of our campus here in Utah. You know, at this time of year, usually covered in snow, but fortunately, we haven't had a lot of snow this season. So the reason why I'm speaking, I think that I was invited to speak, was because in 2023, when I started at the University of Utah, I co-founded a program with my boss, who all of you or many of you know very well, Dr. Jeremy Myers, who've been coming to Rwanda for many, many years to teach reconstructive urology. And the program that we founded is called GU Impacts. It's a very long acronym, stands for Global Urology Initiative and Multinational Partnership for Advancing Capacity and Training in Surgery. And our goal was to be a multi-institutional, team-based program that delivers longitudinal, needs-based surgical training in subspecialty urology in low and middle income countries. I'm also talking a little bit today about IVU Med, which has been a real cornerstone for the delivery of global urology care for many years. IVU Med, for context, is a different organization, but we work very closely with them. It's much older than we are. It was founded in 1995 by a physician named Catherine DeVries, who many of you, I think, have met. She often participates in the COSEXA board exams. So if you haven't met her yet, you may see her there in the future, residents, when you take your exam, if you sit for that. And IVU Med is a private, nonprofit organization that has been dedicated to making quality urological care available worldwide since it was first established. And the primary way IVU Med has achieved this has been by sending volunteer urologists to provide surgical education and patient care to low-income settings. And in the map here, you can see the sites that they currently have programs where they are sending volunteers for all different types of specialties and subspecialty and general urology care. So your IVU Med has had a presence in Rwanda for quite some time, I think dating back to as early 2000s, with reconstructive urology really being first brought by IVU Med there, I believe in around 2010, 2012. And many of you, I think, recognize these faces who have been some of the instrumental people in the early days of IVU Med involvement in Rwanda. Here I have Dr. Frank Burks, Dr. Jeremy Myers, and Dr. Hadley Wood, all of whom first started coming to Rwanda with IVU Med and just fell in love with the environment, the people, the culture, and just saw an amazing amount of potential for partnership there and kept coming back on their own for many years to come. And so IVU Med and GU Impacts were not exactly the same thing, but we are working in partnership. And just a little bit about that. You know, we at GU Impacts are hoping to, our hope was to sort of move away from or build on the historic types of work that are done in international settings. You know, back when global health started as a practice, a lot of programs were what we call care delivery programs. You know, individual volunteers going to provide mission trips, surgical education when possible, but really to provide care on the ground. And now there's been this paradigm shift in academic urology and global surgery in particular, moving sort of away from care delivery programs and moving towards local capacity building programs, which are best achieved through global partnerships. So what is a global partnership? A global partnership is a collaborative effort between two or more organizations rather than discrete individuals that happens across national borders, working together to achieve a common agreed upon goal related to public health or healthcare capacity building. The local party is often a government agency, a national university system, or a national professional society. And the reason why global partnerships have really become such an important part of global surgery and global health is because they help facilitate local surgical capacity building by focusing on education, training, research, workforce development, rather than on just one-off interventions. They promote context-appropriate programs that are tailored to specific country needs, local limitations, and sociocultural considerations. They foster a mutual understanding and shared expectations for progress, and they ultimately create sustainable, equitable, and effective solutions to complex challenges faced by surgical systems in low and middle income countries. And so while IVU Med and GeoImpacts are not exactly the same thing, in 2023, when we established ourselves, we partnered with IVU Med. And the goal in doing that was because they have such a long and profound history in care delivery, and such an amazing network of people who have been involved in volunteer programs worldwide, and a really great sort of reputation and administrative program. And shortly after that partnering, because of the history of IVU Med in Rwanda and because of Dr. Jeremy Myers's history and passion for care in Rwanda and reconstructive urology, we pursued a partnership with the Rwanda Urological Association, which is why I'm here today. And our program that we all came up with together was focused on adult reconstructive urology. And so the way that we've done this, which many of you I think know, is instead of relying on individual volunteers on a one-off basis, is we've instead created, with the support of IVU Med, a team of 6 volunteer fellowship-trained reconstructive urologists from 6 different major academic centers in the United States, all of whom I think all of you or most of you have met at this point. And each of these volunteers has committed to being part of our program for the entire duration. And each of these surgeons has committed to coming to Rwanda and participating in surgical workshops at least once a year for that duration. So the shared vision in starting this program was really to improve access to high quality reconstructive urology care and surgery in Rwanda by transferring surgical knowledge and skills across borders in a way that we all together believe that this could be measurable, safe, and sustainable. The other goal has become to really establish Rwanda as an epicenter for reconstructive urology surgery for patients and for surgical education for urologists in sub-Saharan Africa. So I'm just going to take the next couple of minutes to kind of talk about our collective achievements that we've done and where we're heading. So since we officially started this program and this partnership in November of 2023 was when we first hosted our first sort of official GeoImpacts IVU Med reconstructive urology workshop. Since then, barring one workshop that had to be canceled for the Marburg virus, we've hosted 3-week-long hands-on reconstructive urology workshops per year. So that's been 7 in total. Our group just left last week. We've been prospectively, with everyone's help locally, all together, collecting data on patients that have been presented and discussed at our preoperative Zoom conference, where we discuss interesting cases, potential cases for the workshops. And at this point, we have over 120 patients that have been presented and discussed. Between the 7 workshops, about 100 patients have been operated on collectively. And while those numbers are somewhat impressive, I think the bigger deal is just the absolute tremendous amount of skills transfer that's happened, and the technical development and the real independence in clinical decision making. I laugh a little the last time I was in Rwanda because we were in the middle of a workshop and a volunteer from somewhere in North Carolina in the anesthesia department came over and said, "What are you guys doing here?" And I said, "Oh, we're doing a reconstructive urology workshop." And she said, "It looks like your surgeons are just standing around and everyone else is doing the surgery." And I said, "Yeah, that's the whole point." Thanks for pointing it out. So I've been really excited by kind of seeing the growth, particularly among residents, even just in 2.5 years of the amount of skill. And Theo even went so far to look at the outcomes of PFAD repairs in patients that had surgery done independently with local providers compared to with the support of international volunteers, and found that there were no difference in outcomes. So that's really exciting. In terms of academic sort of collective achievements altogether, our collective group between GeoImpacts volunteers, and RUA members and leadership, we've now had 5 abstracts that have been accepted to major international urology conferences, 3 to the American Urologic Association. Dr. Edouard just had a great one accepted for this year, genitourinary tuberculosis, and then 2 abstracts accepted to the Global GERS conference back in 2024. We also, through this collective partnership, have had 2 now manuscripts that are actually published in print. One that I think many of you are familiar with, which was on the surgical technique and outcomes following posterior urethral reconstruction, that Dr. Ndishme wrote up and is now published in the Gold Journal of Urology, which is, in the United States, probably the #1 read journal among urologists. And we just recently published a piece in Current Urology Reports together on global perspectives on urologic training in low and middle income countries that I'd encourage you all to read. We also, as a group, have a manuscript led by Dr. Edouard that's underway, under review, at BMC Urology, and then a really exciting project that I think many of you heard about last week during the workshop from Dr. Kazel that was led by Dr. Emmanuel and Dr. Clemence, one of the residents, on assessing the psychosocial and economic burden of really living with urethral stricture disease as a man in Rwanda. And this is really exciting because I think it has the potential to really enact policy change, not only in Rwanda, but in surrounding countries that face similar problems. Just to toot your guys' horns a little bit more, Dr. Emmanuel will be serving as a senior co-editor on a special edition of the Gold Journal of Urology that's going to be coming out hopefully later this year on global urology. That edition is going to be Global Voices in Urology, Capacity Building, Context-Specific Outcomes, and Education in Low and Middle Income Countries. So he's serving on a very small board of co-editors to help select what goes into that special edition, which we hope will become an annual edition. And Dr. Edouard will be providing an invited editorial along with Dr. Emmanuel for this edition. And then lastly, in terms of academic achievements, both Dr. Edouard and Dr. Emmanuel have been appointed as adjunct assistant professors of urology at the University of Utah. And then a couple more achievements and where we're heading. So grants, collectively, we applied for a grant at the American College of Surgery. We were successful in obtaining it. So we were awarded as a group really to the Rwanda Urological Association, the International Opportunity Fund grant to deliver a multimodal training program in urinary reconstruction and bowel surgery, which we're really excited to hopefully put on later this year once we have some nuts and bolts figured out. And then through our collaboration, we also attained a small grant from the University of Utah Center for Global Surgery to support the development of a dedicated reconstructive urology surgical program in Rwanda. And those funds were used in partnership with funds from the Ministry of Health to co-sponsor Dr. Ndayishimiye in attending his one-year dedicated fellowship training program in reconstructive urology in Mansoura, Egypt, which I'm very proud to say he is back home and has successfully accomplished, making him, to my knowledge, the first formally trained reconstructive urologist in East and Central, and maybe even South Africa as well. So congratulations on that achievement. And so kind of where are we going sort of with all this relationship building and this partnership and what we've done together so far. And I think over the next 3 years, our focus is going to be working with RUA and the Ministry of Health on helping to establish really a dedicated reconstructive urology surgical program where patients can easily access care for reconstructive problems on a regular basis, and then supporting the development of a curriculum for what will hopefully be a future completely locally led fellowship training program in adult reconstructive urology based in Rwanda, where urology residency graduates can spend ideally 1 year or 2 years receiving dedicated training if they're interested, very similar to how I received my dedicated training in reconstructive urology at the University of Utah, but helping Rwanda establish what will hopefully be the first program in sub-Saharan Africa where residents, graduates will not have to travel outside of sub-Saharan Africa to get this type of training. And sort of in support of that, we are in the final steps of executing a memorandum of understanding, or an MOU, between RUA, the Ministry of Health, and our University of Utah GeoImpacts Initiative to help support that program development. So the hope overall is, I really think it's feasible, which is just so exciting for so much progress to have been made in such a small amount of time, but is really to help facilitate and support all of you in Rwanda becoming a leader or a hub for reconstructive urology patient care and training for the region, and working together so that we can become, the Rwanda Urological Association can be instrumental in improving patient access to high quality reconstructive care in sub-Saharan Africa. And my hope, or one of my hopes, which I'm sure many of you share, is that this model or something similar, as we grow it and figure out what works and what doesn't work, ideally can be used to develop other urologic subspecialty programs. So I think I might have went over time a little bit, but I really appreciate being here. It has really been just such an honor to work with all of you for the last 2+ years, and to get to call many of you some of my really close friends and colleagues. I'm pregnant, so I'm becoming a little emotional, but I'm really just so proud of everything we've accomplished together, and I commend you all for your commitment to improving care in Rwanda.
Thank you very much, Dr. Jane, for very insightful presentation on the national collaboration and partnerships. So, I don't know whether there are questions in the room, taking into consideration about the time limit. Well, looks like the presentation was self-explanatory. I thank you, Jane, and hope to see you in the next emission.
Yes, me too. Well, thank you again, and I'm going to stay on. I'm just going to mute myself. And
so thank you very much for all the work that you have been being done with our partnership with GeoImpact. So the Rwanda Urological Association would really to express our gratitude to you and your team, Dr. Myers, Greg, Frank, and all the rest of the team. These past years, the reconstruction has been here for since 2012, I think, but the last 4 or 5 years has been very. They have been very active, and since GeoImpact has been involved, we stepped further, and so many patients have been operated on, skills transferred. We have now freshly graduated uroreconstructive surgeon, Dr. Theophil, and as Jane presented, we are finalizing an MOU, which is being should be now signed very soon within the Ministry of Health and GeoImpact and the RUA. So it's tremendous progress, and we really thank our partners, and we hope that as we wish, Rwanda is going to be a real hub for reconstruction, but also for other subspecialties. Thank you so much. Without delaying, our next presenter is going to be Dr. Monwa Maxime. She's a COSEXA trainee. She's in her last year of training. She's going to take us through the output of the Urological workshops in 2024 and 2025. Welcome, Maxime, on board. I would like also to remind to all presenters that we try to stick on time.
Good afternoon, everyone. My name is Maxime, and I'm a PGY5 urology resident. So I'm going to take you through the output of the outreach. This is not a presentation. Patience. This is noted. I wanted to talk about the output of these GU Impact IVU Med missions that we've been having for the past 3 years, from 2024 to 2026. And it's more of highlighting again what Dr. Jane has just mentioned. These are some of the pictures with some of the consultants and trainees doing the reconstructive surgeries. So, do these workshops matter? We have been talking about cancer, but we've also mentioned that it requires advanced urological care, and it was still limited in low resources settings, like in low and middle income countries, and in this case, Rwanda. So for years, we didn't have advanced urological care to treat complex cases, and we needed to transfer these surgical skills because we will not have these visiting surgeons forever. We need to transfer their skills. I'm so sorry, but we have to steal some from you because we need to strengthen local teams. So we did that by conducting voluntary national and international collaborations. So these are just the numbers from 2024 and 2025 from mainly the 3 referral hospitals or teaching hospitals, CHUK, King Faisal Hospital, and CHUB. The partners have been, of course, IVU Med, GU Impacts. Some were for 5 weeks or 6 weeks. And these are the total patients, the number of patients that we've worked on. In 2024, it was 112. And in 2025, it was 144 patients that we've seen. This is for screening. But the surgeries, in 2024, it was 86 surgeries that were carried out. And then in 2025, 82. In just last 2 weeks, we operated on, I think, 8, if not 10 patients. So this is just showing the main surgeries that have been carried out. The main ones, the one in the purple, they were complex urethroplasties. So the complex urethroplasties, these were the cases that had been operated on, and then they recurred. They were operated on again. Some of them were for the gracilis flaps. Some of the cases that we were not comfortable doing on our own. So these were the main cases that were operated on, followed by hypospadiasis, and then penile reconstruction, ilioconduit, ilioureter, and just last 2 weeks we did one. And then for the cancer, for uro-oncology, it was mainly blood augmentation, radical prostatectomies, cystectomies, nephrectomy, and adrenalectomy. Next. So for the patient profile and access, we worked on 225 adults versus 31 pediatric cases. And we had 251 males versus 5 females. The 5 females were mainly for DSD. And in all this, for this to be carried out, we were lucky to have a smooth referral pathways, though we had some challenges because some of these patients need to be approved by RSSB or their health insurances, and it was not easy to convince them to, especially for those that were coming to be operated on at King Faisal Hospital. So, but we hope in the future that it will be a lot smoother. And of course, the main goal was that these cases, because they were complex, they had waited for a long time. So these long waiting patients were finally treated. In terms of training and skills transfer, there were 18 urology residents that were lucky enough to have hands-on experiences, 7 consultants with nurses and anesthetists, because we understood that for these cases to be operated on here, it has to be a team. It's not just about the surgeon. You need anesthesia team that understands what you need. You need nurses that know the equipments or how to run the theater, so for you to be able to carry out these complex surgeries. The number of successful procedures was 168. We had some complications. Surgical site infections were reported in 3 patients, and most of the minor complications could not be assessed. We did not have any perioperative mortality, and the post-operative follow-up was arranged locally. And we had come up with a system of making sure that we keep recording the outcomes from this patient. And we are currently having one of my colleagues carrying out a thesis about these patient-reported outcomes post-urethroplasties, to make sure that we follow up on these kind of patients and record their outcomes. These were the number of volunteer surgeons. We've had 12 volunteers in plus. By volunteer surgeons, it's because usually the team is made of the faculty, and then they usually come with a fellows and a resident. And sometimes they will also come with medical students from their universities. So we had more than 12. We had total volunteer days from 2024 to 2026, 77 days. I mean, counting the screening days and the operative days. And of course, we had combined local and international efforts. This matters nationally because it has reduced the referrals. These are some of the cases that we used to refer abroad because we could not carry them out here. And of course, it is cost saving, you know, both nationally, but also on a personal level to, you know, to the patient, to the health systems. So this is very cost saving. And of course, it reduces surgical backlog because these patients, as I've just mentioned, they really wait a long time waiting for these visiting surgeons to come. We are very lucky that we've been able to have a regular schedule with these IVU and GU impacts. And of course, they were training future specialists, and it was aligning with the national surgical and anesthesia protocols and universal health coverage. We are very proud that we've been able to carry out these complex urethroplasties or reconstructive surgeries. We are very proud that most of our local consultants are able to carry them out on their own. And that means that as trainees, as young trainees, we keep having that exposure. And of course, we are very lucky that for the most pediatric reconstructions were previously unavailable, at least for in urology. We have a pediatric surgeon here. I don't want to talk on behalf of pediatric surgery. But of course, it was a multidisciplinary teamwork because everyone has seen the impact of these missions. So everyone, whenever any is called on board, they all join and we carry out this tremendous work. The lessons, as I've just mentioned, we need to collect data to make sure that they guide even future missions, because to make sure that we keep identifying the gaps, where do we need to put more efforts, what have we achieved, and what do we need to do to make sure that these care get to all the patients that are in need. For the equipment gaps, they remain, but we're very lucky that our institutions are really willing to help in and ship in whatever we need. So, as I finalize, this is a model worth supporting. As you can see, this output in terms of numbers and in terms of the work that has been done, it demonstrates that Rwanda can deliver high quality care. that you don't have to go to India, you don't have to go to Kenya, you don't have to go to any other country. You can stay here and save a lot of money and still get the best or high quality care. Thank you.
Thank you very much, Maxime. I'm going to call upon my boss, Edouard. So the next presenter will be Dr. Ngendahayo Edouard. He is going to talk about lessons from a single urologist outreach 2023-2025 from one to many. So as he has been present in the morning, he's the chair of Rwanda Urological Association, and he's also a consultant urological surgeon at King Faisal Hospital, Rwanda. And he has been involved in different surgical outreaches, mission, and district hospitals, east and west. Welcome, boss.
Thank you so much. Theo was telling me about what we can agree upon about the presentations that are remaining, but maybe after I talk and Professor Salami talks as well, we'll agree on the next steps so that we save time. Thank you so much. I want to talk briefly about my experience in outreach. It's a 2-year experience, and I thank so much the leadership of my hospital that allowed me 2 days a month, to which I added 1 day from my own to support a bit Eve alone in the south and to develop skills learned from the professors here and from abroad. You saw all of them. Next, please. The inspiration comes from the first picture on the left side. The picture I saw in 2008 when I was starting with Edmond, the pediatric surgeon there, my residency in general surgery, that made me reflecting on penile cancer and the way we were treating it. Next. Surgery doesn't require much, but how we do it on a voluntary basis. I think it's time that, the policymakers, our Ministry of Health support our urology outreach, focusing on urology. And I think you can achieve much. But also, even if we can do it on a voluntary basis, people should remember that we are in the 21st century. They should remember that the residents, if they agree to come with me or any consultant, we have children. We do the homework with children. There should be at least the minimum support, transport, accommodation, and some allowance. And we can achieve a lot. Unfortunately, we made a project, but we are still working on that shows that we can go for a week, a team, and then another team, a week. Working on all these cancers that you saw. If we have a big team, we can perform cystoscopy for hematuria, we can do PSA and digital rectal. Now it is covered by CBHI, we can do biopsy under local anesthesia for these lesions, we can do ultrasound for people with abdominal discomfort. All our cancers can be detected at low cost. We need support from the Ministry of Health. We need support from RBC. Even if they are not here, we'll make a report. I thank you so much. Keep thinking on how we move from one to many as IVU Med, teach one, and reach as many. Thank you so much.
Thank you, Chair, for sharing with us your experience with the Outreaches mission. Allow me now to call upon our friends and partners from the University of Michigan, Dr. Simpa Salami and colleague Dr. Halle. So Dr. Salami is an associate professor of urology at the University of Michigan, and they are very committed to run HIPAS to develop and conducting a locally owned fellowship training into urology. Welcome.
While our slides are getting picked up, I thought that on behalf of Dr. Patrick Lewicki, our fellow, Dr. Lindsay Harrell, and Dr. Stephanie Kilb, who is a long-term partner of Rwanda Urology Association and also on Zoom listening in today, I'd like to express our appreciation to the entire Rwanda Urology Association for your warm welcome and hospitality, for allowing us to partner with you in advancing urology care here in Rwanda. And I also like to congratulate Edward and the entire Rwanda Urology Association for this historic symposium. Really, we count it as a privilege for you to allow us to be a part of this historic event. Thank you. So what we like to do today is just talk about the initiation of the Urological Oncology Fellowship in Rwanda, some of the steps that have taken place to get us to this point. But before we do, I thought we'll briefly introduce, who we are. I already met many of you. I'm a urologic oncologist at the University of Michigan. My clinical expertise is in prostate and kidney cancer. I perform robotic and laparoscopic surgeries for kidney cancer, robotic surgery for prostate cancer. I run a lab that is focused on biomarkers for those two cancers, biomarkers that can re-stratify the disease and also help assign the right patient to the right treatment. And part of my job also is to lead faculty and leadership development for the Urological Cancer Center.
And I'm Lindsay Harrell. I'm also an associate professor at the University of Michigan in urology. My expertise is primarily around bladder cancer as well as kidney cancer. I do kind of the other realm of research. I am in health services research and policy research. I also work in hospital administration and operations. I am the medical director of our operating rooms at our main hospital. And so I think it's really interesting to come here and see some of the challenges that you guys face and that we similarly face in Michigan. And so it's fun to find common solutions to common problems that we have. So we wanted to talk a little bit about why a fellowship in urologic oncology and why now. So as we've discussed at length today, there's been a rising incidence of genitourinary cancers here in Rwanda, and it has a disproportionate impact on mortality in developing countries. Interestingly, workforce shortages, from everything we've heard today, seem to be the dominant constraint, but I think what's really helpful to understand is that they recommend a tremendous opportunity as they're modifiable factors. So you've seen these workshops take place where we've been able to train and transfer skills, and that allows the local workforce to be able to treat these problems. So thinking about the currency of a partnership and what we can help transfer skills-wise to each other. From our standpoint, you guys see a lot of bladder, kidney, and prostate cancers. We see tremendous numbers of these as well. And so helping think through both the evaluation and patient selection of who we're going to operate on and who we shouldn't, and what other management opportunities there are for patients with these cancers, particularly some of the advanced cancers that we've seen. We in the US tend to not have a really high rate of penile cancer, and so this is something that we have a tremendous ability to learn from you all, and one of the reasons that we would like to continue to bring some of our trainees here is to learn more about penile cancer and how it's treated in a high volume center, and also work towards learning more about a very comprehensive lymphadenectomy, because as Edward pointed out, this is a surgically curable disease even when there is disease inside the lymph nodes. From an educational standpoint, we are starting to focus on tumor boards, so we currently meet once a month to review cases, and these will expand and grow with time. And we hope to move these to continuing to be a very multidisciplinary with our colleagues from radiology, pathology, medical oncology, radiation oncology, so that we can really have a comprehensive multidisciplinary assessment of patients and outcomes. Conferences such as this one, and we hope this will carry on in perpetuity, as well as inviting you all to come to the American Urological Association, which usually happens in May, are great opportunities to exchange knowledge together. From a research perspective, learning a little bit more about the epidemiology of urological cancers. The distribution of cancers that we have in the US is different from the distribution of cancers here, and I think we can harness that to learn from each other and how we're treating and assessing cancers. The stage of disease also is highly variable from what we see in the US, and so that's helpful on both sides to understand how we can impact disease trajectory. We've learned a lot about screening and early detection. If we go back a slide. In the US, and so as we're starting to think about screening cancers here, thinking about kind of what lessons have we learned, what has worked well, what has not worked well, for things that we've identified as problems in the United States, we don't need to repeat those problems. We can kind of move past them and have a better system moving forward. It seems like there's already a pretty well-developed cancer registry, but having some of that ongoing data collection, as Jane pointed out, is really important moving forward. And then understanding the intersection of this with health policy. All of this requires funding and a really strategic vision of how things will move forward from a patient perspective, insurance perspective, government perspective, educational university perspective. And so what are the components of building a partnership? You need people, organizations, and infrastructure, and government, which also comes with funding, to help build this partnership and move forward. And so here are some of the key people that are part of this partnership. We took this picture yesterday when we were presenting the curriculum to the University of Rwanda chair of surgery. And I think that we cannot overemphasize how key it has been to have this group of people together to build this partnership. We've worked with other groups that have not had local people who have been interested, and it's really just fallen flat. And so having the opportunity to come here and work, and everyone that we've met has been so engaged and continues to build this together. This is a couple of photos from when we were here in August, which was our very first trip here. So in just 6 months, we've been able to really build out this partnership, and it is entirely possible through the work of people here on the ground. So we can't thank you enough, and we're really excited to continue to build this partnership. Beyond just the people, there's organizations and infrastructure that can support a program like this. The Rwanda Urological Association, the folks at King Faisal and the University of Rwanda, our local support that we have through both the University of Michigan and Dr. Moses at Vanderbilt. COSEXA will be critical in terms of trying to create a certificate program for this and us interacting kind of across the region. IVU Med and GU Impacts also remains critical as we move forward with building out a workforce that can continue to come here as well as exist on the ground locally here in Rwanda. One of the things that we were not sure about when we first started coming here, but I was reassured by both Dr. Moses and Stephanie, is kind of what resources we would have on the ground. And we were highly impressed when we walked into the operating rooms and saw a cardiac bypass machine and as well, back one more. Some of the anesthesia setup, these look like things that we see at home, and so this was very reassuring for us and kind of gave us the idea of what all can we do from a complex surgery standpoint. Can we do a cable thrombectomy if that is warranted, and we have bypass abilities, so that works out great. Understanding biopsy turnaround, interventional radiology capabilities, anesthesia. We were able to meet with radiology and review images together, so the people are here and happy to work with us and help us understand what's going on and kind of more details of complex care that we've been seeing here. We've noticed tremendous growth, which obviously is supported by the Ministry of Health. This is in picture from the last time we were here in August on the left, and then on the right, and you can see there's just an enormous amount of growth going on, and it's really exciting to be a part of that. And eventually, as these buildings get built, we need to have people be able to occupy them, from both patients, all of our staff, our nurses, highly trained, but also the workforce to be able to deliver care here. One final piece is thinking about some of the organizations that we have. There has been investment both from the government and King Faisal and the University of Michigan. We walked into the anesthesia lounge during our first trip and saw this mouse pad that says University of Michigan Kidney Transplant. And so that's been a really successful partnership between the University of Michigan, King Faisal, Ministry of Health to build up a skill set. And that's exactly what we would like to do with urologic oncology, maybe a little bit bigger. in terms of incorporating Vanderbilt and other programs, but we're really excited about it and we've seen it, work really well. And so we would like to continue to build on that. One of the highlights from our visit in August, I think we've all heard these stories today of people who present with advanced disease. This young lady on the left, she was only 38. She presented with a palpable abdominal mass and flank pain for years. And you can see her imaging there on the left, a very large kidney tumor. And then when we got the specimen out, she had invasion both into her renal vein and her renal pelvis. And so she had very advanced disease. Which, our hope is that we were able to cure her of this with surgery. So much better to get her back to her life, get her back home with her family, and be kind of a functional living member of society rather than be suffering from this. And I'm going to pass it over to Simpa now.
Thank you, Lindsay. So when Lindsay and I visited last year and had done some open cases, and one of the residents asked if we could do laparoscopy, and Lindsay and I looked at ourselves mainly because we were not prepared to do a laparoscopic case here. So we asked what resources do you have, and they showed us the equipment, the lab tray, and we had Danny who went around to show us all of the different laparoscopic instruments and ports, and okay, so let's do it. And we're able to successfully do a lap nephrectomy for a kidney tumor last year. And what this really highlighted for us is the fact that you have the resources, you have the tools, the people, and in the appropriate patient, minimally invasive surgery is possible here. And that also highlights the importance of early detection at a point where you can offer a minimally invasive surgery that will be associated with faster recovery for patients. And one of my joy is really teaching, trainees. And this trip also gave us the opportunity to be able to work with the residents. Here are some pictures showing Edward, myself, and Lindsay, walking the residents through prostate biopsies in clinic. And we're looking forward to another session on Monday. We have a number of biopsies lined up for us, and we're looking forward to that as well. I think, taking everything together that you've heard from Dr. Harrell and from the different programs that have already been established here, all I can say is that you have everything that you need to be able to establish a urologic oncology fellowship. And the question is, why not now? So our vision is to help create a urologic oncology fellowship that can lead to providing high quality oncology care for Rwandan citizens. And the goal, as you've already heard from the various other programs, is to make Rwanda a regional hub for oncology care in East Africa and beyond. I think, Maxime said it very nicely. There's no reason for patients to be able to go out. I think what you need to be able to provide the care you have here. And our goal is to be able to help develop the people to do that. And Edward has assembled a fantastic, team to help do this. And just shown here, those who will be leading the fellowship program, and we have other participating, faculty. You already heard from Kelvin Moses. I think, Kelvin stole my thunder about highlighting the relationship that he had with Lindsay, and I know Kelvin as well very well over the last 10 years. And I think with the partnership between University of Michigan and Vanderbilt, we're positioned to work very well together in helping you achieve your goal. And as Edward mentioned earlier, the fellowship program is already approved at the level of the Department of Surgery, and we're just working through some additional paperwork, and hopefully in the next 6 months we'll have it formally launched. But what I thought I would do is just highlight some of the structure of the program. It will be a 2-year program, and we'll have faculty coming from mainly the United States, but we're potentially going to be working with other faculty from other countries who already come here to provide care. And we'll arrange for surgery boot camps for like 1 to 2 weeks duration every 1 to 3 months, just depending on the case volume. And as Professor Africa highlighted earlier, this is designed to facilitate a multidisciplinary exposure to urologic oncology. So there'll be rotation structured for exposure in medical oncology, radiation oncology, pathology, and radiology. And Lindsay already mentioned that we already have monthly virtual tumor boards, but we will increase the frequency as needed depending on the caseload. There will be opportunities for leadership development, as well as a research project to be completed with a dissertation presented at the end of the fellowship program. And I think someone mentioned this earlier. I think the goal really is for the fellowship program to become self-sustaining, to become independent, where you don't need us anymore. we only come, at a point where we'll probably just come here to escape the cold in Michigan. I think that's what we'll be looking forward to in 5 years. The rotation sites will be the 4 main hospitals in Kigali and the cancer center as well, because they offer radiation therapy. But in addition to that, we'll also have rotations in the United States, 1 month rotation at Vanderbilt University. You can advance. Rotation at Vanderbilt University as well as University of Michigan. And at some point, we may even be able to find other partners where fellows may be able to rotate at. And the core rotations we focused on surgery at those 3 different hospitals, and then there'll be 1 month of medical oncology, radiation oncology, pathology, and radiology. There'll be a community outreach integrated into the rotations, and that's really important because we want to go to where the patients are to be able to facilitate early detection of disease before they become, advanced. And there will be a research project to be completed by fellows, and Edward has been gracious enough to create a little time for you to take vacation as a fellow participating in the program as well. So how would we measure the impact of this program to ensure that it's doing what we want it to do? We'll look at the number of fellows that are trained through this program and choose to stay and provide high quality oncology care for Rwandan citizens. And we'll be looking at surgical volume and outcomes of the surgeries that are performed. In particular, we'll look at stage migration. We want to decrease the number of stage 3 and stage 4 disease in the various cancers that we treat to potentially stage 1 and stage 2 cancers. And we'll also be looking at the research output and the educational output of the fellows, abstracts presented, papers written, and dissertation completed. And we'll also be looking at the number of U.S. trainees that are participating in the program as well, coming to join in training their colleagues here. That would include residents and fellows. And we'll also be looking at the number of cross collaborations we are able to establish with other organizations that already come here and potentially other institutions within the United States as well. So in conclusion, I think to achieve equitable cancer outcomes, you need equitable expertise, high quality oncology care being provided. And that is what I hope that the Urological Oncology Fellowship will facilitate. It will help build the capacity that is needed to provide the highest quality oncology care for Rwandan citizens. And Rwanda can become a regional hub for urology cancer in East Africa and beyond. With that, I'd like to say thank you, and we appreciate the hospitality. Just one quick thing about your hospitality and the warm welcome. We've come to love Rwandan beer. I think at this point our favorite is Virunga Gold, and maybe in close second will be Virunga Mist. Thank you.
Another round of applause for our friends and partners. Thank you very much, Professor Salami. We still have one more presentation, then we go for the panel, and then we close our day. So bear with us. Dr. Mona Maxime, can you please step forward again and take us through the lessons from a nationwide prostate cancer awareness and screening campaign in Rwanda? So whoever has a question, please note it down. After this one, we are going for a panel discussion, then we wrap up for the day.
Okay, so since this morning we've been talking about early detection, prevention, going to the community level, and there was a question from Queen on what are we doing on this early detection complaint. Yeah, so this one is one of the things that we did about the early detection. I hope you're going to like it. So prostate cancer is the most common cancer in men worldwide. And in Sub-Saharan Africa, it ranks as number 1. And in Rwanda, is again number 1 in terms of mortality and age standardized incidences. And for us, we have found that 85% of prostate cancer patients that we have get diagnosed at already advanced stage. I've just mentioned this. So after realizing this, we try, as Rwanda Urological Association, we were like, what are we going to do about this? Together with RBC, Rwanda Biomedical Center, and the Ministry of Health, we thought of a campaign about awareness, going to the community levels and meet with patients, because we found that one of the reasons why we are diagnosing prostate cancer at advanced stages is because these people are in the community, they have symptoms, they don't know it could be prostate cancer. So we conducted our campaign through radio and TV messages, and we ran a prostate cancer awareness and screening campaign in October 2022. We targeted people, males aged between 50 and 70, and we did that at 4 referral hospitals across the country. This is the map showing the hospitals we went to. So the team at each hospital had 2 urologists, 1 urology resident, and a data collector, because we needed to record the patients that we've seen and the findings. So we were giving 2 days per site. So in the morning, it was for morning educational sessions, and we were distributing leaflets in Kinyarwanda about prostate cancer. And we did digital rectal examination, digital meaning finger here, and not on all patients though. And then we were doing PSA requests. The data that we collected was about was mainly the age, the numbers, because we needed to follow up on the results of the PSA for those whose PSA were requested. The residence details, the DRE findings. We looked at lower urinary tract symptoms, comorbidities, and the PSA levels. We educated 1,340 men, and the average age for the attendees was 65 years. So we realized that we had increasing LUTS, prostate volume, the suspicious DRE findings that increased with age, and the surveillance indicated a high prevalence of men with suspicious DRE, because we had 214 out of 595 men on whom DRE was performed. These are just showing the mean prostate volume on the men who underwent DRE. Again, these are the findings. Those who had suspicious, non-suspicious lesions, and on this side, it's a graph. It's a diagram showing the findings about lower urinary tract symptoms, and what these 2 diagrams are showing is that, of course, the suspicious lesions and the gravity or the severity of the LUTS, whereas they were increasing with age. So as a conclusion, we saw that the high prevalence of suspicious DRE was emphasizing the need to follow up these PSA and the subsequent diagnostic testing. Research shows that DRE has a positive predictive value of about 41%, and it suggests that 88 of the men that we examined had prostate cancer, because 214 out of 595 men on whom DRE was performed had suspicious lesions that could be prostate cancer. This also shows that in the future studies, we need to collect data about lower urinary tract symptoms with standard scoring metric like IPSS score, and we also need to include data on family history, because early in the morning, Dr. Theonest mentioned about the fact that we are currently having more men around 45 years old, 50 years old with advanced prostate cancer. And that could mean that there's a high likelihood that they might be having a positive family history of prostate cancers. Thank you so much.
Thank you very much, Maxime. Allow me to call upon Dr. Ngendai Edouard to come and introduce the panelists, and which will be our last session for this very long and insightful day.
Thank you so much. I think I'll make it too short because I will not introduce anyone. I would suggest that Dr. Ndaize, please come back. And Dr. Ndaize comes from Rwanda Social Security Board. It is a big institution because it is the one that treats all of us. So we don't take it for granted, Dr. Ndaize. But the people here should also know that you have been a good leader at university when you were students. Professor Wamasirabo, I would like you to please come back because when we end the session, you remain and give us the closing remarks. Dr. Harold Lindsay, please come back because of your research interest. It goes to the population that needs cancer care. And finally, Dr. Zawadi Muvunyi, this one I will introduce him in a few words. Please come. Dr. Muvunyi is the chair of pathology, and indeed he's the one who dressed the, the roadmap of pathology at King Faisal Hospital, but also at Rwanda Military Hospital. He's a senior consultant, and he trained in Nairobi, but he had a fellowship in kidney cancer in the US. Not Michigan, he mentioned Boston. It was at Boston. So he has a good experience, and we'll talk about pathology a bit. And so maybe I start with Dr. Harold Lindsay. You have been advocating for people to have access to care. And this session we've mentioned that how can we rather, instead of navigating patients, because the concept of navigation comes from your country, where the founder wanted to, to try to remove the barriers of patients towards the cancer care. After hearing what we have been discussing here and your practice over there, what would you advise us to have early detection of urological cancer? Thank you.
I got help. So we see some similar challenges in the U.S. to here in some of our more rural communities and even some of our vulnerable populations that live in larger cities. I think a lot of it will ultimately come around to education, and this was brought up earlier. But I think there needs to be kind of a multifaceted educational plan that comes out. We need to build the workforce, but then we also need to build, training to the community health workers, because they're the folks who are in the communities interacting with the patients, build the resources at the health centers, and every level needs some basic level of education of what we should be looking for based on what role they play with patients in the community. I also think that patients themselves are wise enough to understand when there's a problem, and oftentimes they go to try to get help and then are turned away. And so continuing educational efforts of understanding that blood in the urine is not normal, and what they can advocate for on their own. And I think all of those components, as we continue to build the workforce, should be an integral part of that educational plan. So we talked about outreach within the fellowship, of people going to the community, delivering educational programming, both, to community health workers, patients, health centers, district hospitals, knowing both when to refer, how to treat things that they can treat, knowing when to refer, and the speed at which they need to refer, because there's a lot of things that probably are overly delayed, and if we can skip a few steps and get them here sooner, that may heavily impact their care.
Thank you so much. Dr. Ndaize Nwari, we're happy to have this symposium when the Ministry of Health had released already what you as RSSB, but especially CBHI, accepted to cover for patients with cancer. We understand that you cannot cover every patient. And what you did, what you committed to do is amazing. Even if we mentioned that the bladder was not part of it and the bladder cancer is a challenge, would like to request you, if we could save some money that we see that is being used for unnecessary causes or for following ignorance of us clinicians, would you like to suggest that this money covers also patients with bladder cancer? And if not possible, does it mean that a patient coming with hematuria, with bladder cancer, will not have at all any support? So we want to understand what you think about that. And then afterwards, I will show you where is money, where we can get more money in what we use. We don't use appropriately. Thank you.
Thank you. As you can understand, our business in health insurance as a doctor or clinician is about cost containment. This is the job, because currently we are estimating every year a loss of 20 billion Rwandan francs, either through waste or overbilling or fraud. And it's a huge money, which can also finance any other project which is not yet supported by now. We still think also to raise money through contribution, so we can add and open other new services. As you may know, we started by covering life savings conditions. Currently, we are going step by step for the disability and also cancer. There are many cancers which we currently cover diagnosis, surgery, radiotherapy, and even chemotherapy. But for the remaining cancers, those you are saying like bladder cancers, still, even if we don't provide currently the chemotherapy, but the diagnosis is provided, we are also supporting I don't know if the radiotherapy is the indication. It can be used for the bladder cancer, I don't know. But if there is any need of surgery or radiotherapy, it's also covered by mutual. The only things for the few cancer, which is still remain, it's still pending to be covered, is the chemotherapy. And I'm sure that with the time we'll achieve and we'll make sure that we reduce the burden of out-pocket to Rwandan population. This is our aim, but we can achieve it by the effort of everyone, as you said. If we can reduce the waste, if we can reduce all those overbillings or all those bad attitudes, we expect to save more than 20 billion, which can finance any project or any program in the insurance.
Thank you. We want to support you with evidence of money that is lost on a PSA prescription. We did an exercise. We had a workshop, oncology and urology, after seeing that sometime PSA was not covered. And we guessed maybe the insurer is seeing that, numbers are increasing. We consulted the guidelines and the evidence in the literature. And then we proposed an algorithm of PSA prescription, starting with the age. At which age should we start screening? And then going to the type of PSA. There's a free PSA and total PSA. Free PSA has a limited role, only in the gray zone. When you have a patient with PSA 4 to 10, and you want to know the probability of getting a cancer. Otherwise, free PSA has no role. But in hospital, I have a chance to go to different hospital. They request for free PSA, and free PSA 30,000, and the total is 20,000. They request for free PSA that cannot give us anything in the diagnostic purposes. When you see a clinician seeing a patient, is 40 PSA. PSA panel, meaning both PSA. There is an overuse of PSA. Please accept our collaboration to show you the prescription algorithm and then to spread it to all clinicians so that we save that money. I think I'm not wrong. If I'm wrong, you tell me. Maybe there is a new literature, but we'll save billions that can go and cover those other cancers.
This is a good initiative, and I'm happy for this conversation because, as you are saying, most of the time when there is an escalation, the file comes to me, and most of the escalation is when the patient is complaining. Let me tell you the truth. I had one patient who came to me complaining that we refused to reimburse his PSA. And I said, the last time you had your PSA is when? I said that it was last month. And for his information, he was supposed to do PSA every month with the normal PSA for the previous PSA. I know the person. If someone doubts, we can discuss about it. You know the problem we are facing today, which is, I know the patient, I know even the doctor. Anyone want to discuss, I will ask the patient if can accept to share the name. But we had that discussion with the patient. The doctor was not there, but I had a discussion with the patient. You know we know we are facing many private health facilities who sign a contract with the doctors. The content of the contract, it's more kickback. It means I will pay you based on what you will enter for. Yeah. Already, we are more exposed to those issues of kickbacks. And sometimes we can also miss our scope of practice only because we need to generate money. Yeah. I'm sure that if we can work with professionals, like the way we started today, yeah, the saving of money can be possible. We can contain more losses, and we can even use that money to invest for other programs which are not yet financed. Yeah, because we are managing a public fund. That means there is no one who needs a return of investment. The return of investment is a Rwandan. That means any additional fund, any additional saving money will come to finance a project. That's what I'm calling all of you doctors. Help us on this journey. Make sure that we are not losing money to finance corporates, but we are using money to treat people.
Thank you so much. We write a concept note and request for appointment. We come, we show you how we can save money and save more lives.
Yeah, this is granted.
Thank you so much. Dr. Zawadi Thierry, I wanted to talk briefly about the service of pathology. I started my outreach to Kibungo. I stopped with Butare because I saw they need me. And I hope to go with residents, and I already started. If I call patients from the region with penile lesions so that we take biopsy, it it will be a problem because there is no pathologist. And I think we have many pathologists. And I think in one discussion we had with you, yourself see that you can do more. That means all these specimens, you can even read them, like a limited time. Would you support district hospital with reading the pathology specimen, either on a contract or another agreement that we can make so that any biopsy we do in periphery is read by a pathologist? The hospital I was giving you as an example has no pathologist. But again, we'll ask Dr. Ndaize and Dr. Nwari if that time they will cover. Actually, I want also to know, will you accept my services? We start with him. You want me to repeat the question? I will go to Chibungo. Chibungo is a level 2 teaching hospital. I can carry, biopsies of different lesions. There is no pathologist. I wanted him to provide support because pathologists are many now in the country and read. But also I want to know if you recover what I do as urologist in a level 2 teaching hospital. I don't know from who I should start. Want to start with you maybe? Would you support? You know better? Not serious question. Okay.
I can understand when you do an outreach. Normally in our policy we support outreach. But the problem is about the communication about outreach. Because we need to get communication about what is going to be done instead of seeing a raise of the bill. Because when there is a raise of the bill, it's a red flag for us that there is something going on which is abnormal. And when we came, we found that there is something abnormal because someone came from King Faisal and started giving service there. Yeah, this is good, but it's required that we be informed to avoid anything. So far, King Faisal, they are respecting this in the King Faisal when there is any outreach camp. But we would like also to have this done even when you decide to go outside King Faisal or outside your usual hospital. So we can know exactly what we are going to reimburse. So we can understand immediately what is the reason of this raise of billing without making many doubts. I think this is not a big issue since we are communicated.
Thank you so much. We have the guideline on the website? Or the Director General knows how to proceed to communicate?
Okay. Before I joined the insurance, I used also to conduct outreach because conducting the fistula surgery elsewhere, what we used to do, it was sharing the concept note with RSSB. IntraHealth is committed to do A, B, C, and D. This cost will be the contribution of the insurance. But don't request the copayment to the patient because this copayment will be ours. Because normally the copayment, if the patient doesn't pay it, it's a problem. We have to tell them before that this copayment will be our reimbursement, not the patient reimbursement. Because all those mechanisms help them also to plan ahead how things will be. It means every time you want to go there, what will be the contribution of your project there? What will be the patient contribution? What do you expect the insurance also to cover? It could be clear.
Thank you so much.
Thank you, Dr. Edward. First of all, it's my pleasure to be with you. And so thank you for your pathologist. Back to your question, when you look at the Urology Association, it's so better to include pathologists. When you look at it in terms of screening, or you're talking about early diagnosis, it's still, at the end of the day, you need pathology. So reinforcing pathology capacity or access to pathology services is one of the key issues we have to actually work on it. When you talk about the number of pathologists, there's quite enough pathologists currently in Rwanda. And most of the laboratory actually can actually exceeding their capacity even by doubling. So this is should not be an issue in terms of receiving biopsies from the outreach. As Dr. Mwari is saying, just information, communication ahead so that we plan for receiving work on those cases. I think that should not be on our side of the pathology an issue, because also we also work on toward of improving accessibility to pathology services. Rwanda is a small country. When you look at the centers with pathology services, actually they could serve the whole country without any problem. The issue comes in sample transportation. So sample transportation become an issue because the remote areas, there's no mechanism. Actually combined with insurances like RSSB, especially CBHI, who covers, what are the modality for payment, then who made the transportation. Because when you look at it, every single day, there's at least more than 2 cars or ambulance coming from one place to another. So those can actually work as modality of sample transportation. It becomes more expensive when it comes to send patients to Kigali, to the centers. You know, like when you look at the biopsy in most of the centers, it's 35,000. The co-payment is around 3,500. At King Faisal, it becomes half price. That means less than 2,000 for biopsy. So the issues now, when you send patients, the cost of transportation becomes even more unaffordable. So they have to pay a lot of money, they have to sleep in Kigali, all those logistics come affordable. So ASEX pathology should change the way we actually approach pathology services. Sending patients will not solve it. Send specimen, much easier. I'm talking about tissue or specimen in histopathology. When it comes also to clinical pathology, PSA testing, other cytology, those are things can also be the same route with the non-sending specimen, not patients. So that approach with collaboration with the Society of Pathology can really solve those issues and also incorporate, when you're planning the outreach, plan also with pathologists to ease the process. Thank you.
Thank you so much, Professor Rwamasirabo. I have no question to you. I just need you to tell us what you feel, seeing what your trainees did, and then summarize the past, the present, and the future of urology, and we end the session. Thank you.
Thank you very much. You're asking me what I feel. I feel like coming back from my retirement and join the team. I've seen so many beautiful things that are happening. The past, the present, and the future, you know, one can merge them in one thing because they are so close. The past was just yesterday. The today and tomorrow is also merged. Yesterday, when we had our first IVU Med mission here, must have been 2010 or 2011. The first team was a pediatric team. Probably it was the second. So we had a discussion. At that time, we didn't have residency. there was one residency in general surgery. That was it. So we're thinking of residency in other disciplines, including urology. So we had a discussion, and the issue was the IVUMed is providing visits for surgeries. They were visiting countries, operating on patients. So we advised that probably we can combine this with training. And of course, we didn't have residents at that time, but we are thinking. I've started thinking of setting up a residence. So we said, can you help to train our future residents? They said, okay, we can look at it. And I think when they went back home, they realized it was something to think about. And I'm very, very proud that today, colleagues from Michigan, from Utah, from Vanderbilt, Professor Joseph Smith came here, did radical prostatectomy, the first radical prostatectomies we did at King Faisal Hospital for the whole week. They were done by Professor Joseph Smith. So meaning that we have history with also University of Vanderbilt. So I'm so happy to see that at least 2 fellowship programs are on the way. Uro-oncology, of course, has been always, how are we going to develop oncologists? Are we going to be sending people out for many years? That was obviously not workable. The same for other fellowships. So we're very proud to see that at least these 2 fellowships are in pipeline. Of course, we have the transplant that is already there, the kidney transplant program that is already there, and hopefully other programs that we discussed, including, I don't know whether I should mention that one here, men's health, andrology, also which is a public health issue that we need to think, and others. Anyway, thank you so much for University of Michigan and the Rwanda Urological Association for working out the modalities for this fellowship to take place. Thank you also, Jane from Utah, who worked with also Theo and Emmanuel to start shaping the reconstructive surgery fellowship. That's good when you have the people. Why am I saying this? All these programs can work so long as you have the people. When I'm talking about the people that committed, the people that are committed to this. So I'm really proud to see that today urologists, the people that are in charge of urology in Rwanda, have very strong commitment. Dr. Edward, you have seen what the initiative he took to go around and see how we can improve the lives of his fellow countrymen. And I think you need to be awarded a medal of recognition. And I think all of you who are dedicated to continue training of the young ones and also developing urology as it is. The last thing I want to stress also, the majority of your patients require care, and most of the care that require is not really subspecialty care. It is general urology. As you are embarking in subspecialties, keep your skill alive in providing general care, general urological care to patients. This is very important because the way you're going to be training the residents should be reflecting also this concern, because the majority of our patients require basic general urology. You become subspecialists, but also, you understand what I mean? When I send you somebody with UTI, please take care, take care. You understand what I mean? You need the two. Do you agree? Do you agree? No, it is important because you see we are, how many urologists available now? 15? 15. This is still too small. So there is no way you can just looking at your subspecialty, ignoring that the majority of people that need you are general urology patients. I know it is not always easy, but take it as your responsibility to cater for it. That's the future. The future is going to be, I'm sure, you have seen a lot of changes, and some of the changes, many more changes are to come with AI. It is also something that you need to think about. And we've been talking about the cancer, the bladder cancer. By the way, the bladder cancer is not a problem for any insurance. We don't have too many here. I don't know how many have you been able to collect? Yeah, but not as many as the prostate. And many of them are sensitive to just basic chemo. And don't take it as a big problem for the insurance. Have a revisit the decision we made, look at the data, and take it that a patient that comes with hematuria, and many of them come actually with relatively resectable cancers. They are muscle invasive and many are not muscle invasive. So these are cancers that can be controlled, provided there is a minimum support in management. No, these ones are not rare. These are not rare. There is no single month where you don't have a cancer of the bladder in the hospitals here. Yes. So they are not. So please have a second thought about this. Yes.
The benefit package is a dynamic process. The list released will need to be reviewed. The chemo accepted today will need to be reviewed. That means all is based on the demand and then also on the push of practitioners.
So to cut the whole story short, I wish to, is it a closing? I wish to take this opportunity to thank once again the Rwanda Urological Association, its chairman and the whole leadership and the members that came in big numbers to support this program. I wish to also thank all our friends who came from overseas to support this program and who have made the commitment to support us further. All the sister professional organizations, you can see the radiologists over there and others. Thank you so much for supporting this conference. As somebody was saying, a politician was saying, we shall revenge. Thank you so much, and hopefully to meet again when the Rwanda Urological Association calls again for another conference. Thank you so much.
What do you want me to add? The session, the symposium is closed. Thank you so much, Prof. We wish our partners behind to come and have a picture with the Executive Committee of Rwanda Urological Association, because we thank you so much. And Prof, I think it's good you remain there and have a picture of them. They will be done. When I talk about the executive, abajyanama nabo baba barimo Prof, twifotoza na bariya bantu nibo baba baduteye inkunga. Yego. Uridos Group, XFAR, Elite Medical, Boniface, please let's take a picture and end this long and fruitful day.